every exam.
And
Like
of course, that
they're
includes the
all
bladder.
long.
So renal, that's the upper
We're recording
and
now.
lower urinary tract. We've
Just
got
so
to
you
cover
know.
the male system, the female system, focus on the tumors, know those tumors really well, prostate tumor, testicular tumor, breast cancer, ovarian cancers, very high yield. So breast, male, female, bladder, and renal. Pretty big exam. But today, I'm here to show you some skin. So let's get this recording on. Okay, time to show you some skin. Now, I've got great news for you. When you go to a party, everyone thinks, oh man, you're a doctor, right? You're a second medical student, you must know everything. So they're gonna come up to you and say, doctor, what is this thing on my skin? Oh, people love to ask you what they got. So you kind of have to know this chapter. It's going to help you at parties. It's going to help you at family get-togethers. People out of the woodwork are going to come ask you questions. So you should learn some skin. Now, I know most of you are not going to be dermatologists, although it's a great field. You should consider it. You have to know at least the basics. Now, in terms of USMLE exams, not super high yield. They like the tumors, melanoma, squamous cell, basal cell, mycosis fungoides. They like the tumors and maybe psoriasis and some of the blistering skin diseases. Those are going to be the highest yield. But it's high yield for life, so let's make sure we learn it anyway. In fact, in my med school, they did skin as the last chapter. It was the last chapter, so we ran out of time, and they said, go read the book. I learned zero skin, because when they say go read the book, you're not going to go read the book, I know that. So I want to cover this so that way you get a better education than I got. I had to learn this on my own. All right, now why do dermatologists get paid so much? Because skin is another world. They have their own lingo, they have their own terminology. You got to learn a lot of words here. So there's going to be a lot of words and a lot of definitions we'll need to know. But let's start with the basics. We'll start off with anatomy. Here's a nice Trivial Pursuit question. If you're playing Trivial Pursuit, this is a question you might get. What is the largest organ in the human body? It's your skin. It's the largest organ we got. And this is our first contact with the environment, right? This is what comes into contact with environmental toxins, bacteria, and sunlight. Sun's gonna hit it too. So it's very important that we have intact skin. Now notice, it's also important for cellular and molecular interactions with the environment. So there'll be some antigens you'll get exposed to, and your body may react to it. So you can get rashes when you're exposed to certain irritants or certain allergens. Okay, our outer layer, we have two layers of our skin. We've got the superficial layer, which is called the epidermis. So I'm just going to draw this for you. Here is the epidermis. Oops. Epidermis is here, and then deep to that is the dermis. Now, for the epidermis, it's made of squamous cells. Of course, dermatologists have to use different terms. They call it keratinocytes. They're squamous cells, but they call them keratinocytes. Now, they're going to make keratin. So there's always a layer up here of keratin, which is basically dead squamous cells. The nuclei are gone, but it's a nice, strong, protective layer. It also has some oils, too, that'll make it like sealed. So it's like sealed together with some oil. So this is just dead squamous cells. That's the keratin layer. All right, now what other layers do we have in the skin? Well, at the bottom we have the basal cell layer. So we call this the stratum basalis. Stratum basalis, the basal layer. Now the basal layer is very important because that's the layer that is going to generate new cells. So this is your proliferative layer, this basal layer. So stratum basalis, basalis. This is your basal layer. It's your proliferative. We'll see mitosis down there. That's what's going to generate the squamous cells, and then they're going to mature as they rise. They get more and more mature. Now, the basal cells are more up and down, and as they go up, they start to flatten out and become very elongated and flat. All right, so that's basalis. By the way, this is also the layer that UV light will hit, and it will create vitamin D. This is how we can synthesize vitamin D. This basal layer, and also the next layer too. This is called the stratum spinosum. Spinosum. So stratum spinosum. These are the two layers that are going to generate your vitamin D. And of course, if I'm writing a board question, That's not a bad board question. To know the skin makes vitamin D, and it's the lower layers of the skin where you'll actually synthesize the vitamin D. Now they call it spinosum because if you look at the cells, they're kind of more rounding out. They're not kind of up and down anymore. They're kind of starting to get round and they're going to get flat. When they start rounding out, you can start seeing little connections between the cells. Those are called desmosomes. There's lots of desmosomes in the skin. And those are going to create little projections, which makes it look spiky. So they called it spinosum. They're kind of elongated little spikes on them. Those are the desmosomes. Now, as it continues to go up, now you're going to start seeing a granular layer. The granules are these hyaline keratin granules. So you're starting to get these little cytokeratin accumulations, and it looks very blue. A lot of blue dots, a lot of blue granules. So that's what they call it, the granular layer. So granulosum, stratum granulosum. Okay, so it's starting to get really blue, like lots of blue dots, because that's the keratin. Now the next layer is often a lucid layer, so they call it stratum lucidum. Lucidum. Okay, lucid layer, and sometimes it's really hard to see. In fact, a lot of the biopsies I look at, I can't see it. But I can definitely see the next layer. This is where it gets very, very pink, because all the keratin is now really accumulated, looks really, really pink. So this is called the corneal layer, stratum corneosum, corneal layer. Corneal layer. Corneo, I can not spell. Okay, this is the area that you're getting a lot of keratin. And of course, the nuclei are going to be lost here. You're going to start losing nuclei, and it's just pink cells with no nuclei. So that's the stratum corneosum, the superficial layer. And it's a keratin layer, and it's very protective, very strong and very protective. All right, now a couple of things we need to know. This is a protective barrier. Skin, it's going to protect this from the environment. Number two, it's biosynthetic. Not only will it produce vitamin D, but it produces other cytokines that affect adjacent dermal cells. So the skin is actually interacting with the dermis. It interacts by making various chemicals. Now there's also some cells inside the epithelium in addition to the keratinocytes. There's melanocytes. Those are going to give us pigment. That's going to protect us. The melanopigment protects us from UV. It's our natural sunscreen. It protects us from ultraviolet light. Now, where are melanocytes located? They're usually located at the junction. They call it the dermal epidermal junction. This is where the melanocytes are located. They're located at the junction, and they'll be scattered across. Now, what they do is they make melanin pigment, and then they actually inject it into the neighboring keratinocytes, so they can get some pigment to protect the layers as well. Now, obviously, the more pigment you make, the more protection you have. Now, a famous question is, what is the difference between an African American and a Caucasian? Well, under the microscope, we're all the same. We have the same number of melanocytes. The number of melanocytes is the same for everyone. What's the difference? The amount of pigment that is made genetically. So obviously African Americans make more pigment, so they have a darker skin. They have more protection from the sun. Caucasians have the same amount of melanocytes, they just make less pigment. That's another trivial pursuit, medical trivial pursuit. We all have the same number of melanocytes. It's the amount of pigment production that makes us look different in terms of skin color. All right, now let's talk about dendritic cells. What are these cells doing? Well, they're going to process antigens. As I mentioned, this is a first contact with the environment. So we get exposed to antigens, bacterial antigens, chemical antigens. They're going to find them, process them, and then they will actually present them to the immune system. And we have two major types of dendritic cells in the skin. In the epidermis, we have the Langerhans cells. Langerhans cells. These are basically the macrophage of the skin. They'll eat the antigens and then process them and present them to the lymphocytes. Now in the dermis, we have what's called dendrocytes. These are also going to process antigen and present to the immune system. All right, now lymphocytes. We always have a few lymphocytes surveilling. They're just going around because this is this interaction with the environment. So they're always surveilling. Now these lymphocytes, there's a subset that are programmed to go and home in on the skin. That's their home. They're programmed to go there because they have what's called cutaneous lymphoid-associated antigens. So because of these antigens, they actually home in on the skin. That's where they go. All right? Now what's interesting is there's actually going to be a tumor of lymphocytes that we talked about that likes to go to mucosa. It's a tumor of T cells. It's called mycosis fungoides. And the reason it likes the skin is because it has cutaneous lymphocyte-associated antigens. That's what makes it home in, and you'll have a tumor, a lymphoma of your skin, mycosis fungoides. All right, now we also have neural end organs and axonal processes in our skin as well. These are very important. These are going to warn us, hey, there's some sort of physical injury. All right, we need pain receptors to say, hey, we're touching a nail, we're touching a hot stove. So these are going to help us protect us from getting injured. They're also going to assist in neuroimmune modulation. Now, what the heck does that mean? Well, the nervous system can interact with the immune system. Fascinating. So, wow. So your nervous system can actually control the immune function. So when people get depressed, their immune system can get depressed too. Wow. It's amazing, the interactions. We're still trying to figure it all out. But we think that there's cells called Merkel cells in the skin that may be playing a role in this. They're probably playing a role also in touch sensation. So they're important for touch. But they're also important for the interaction between the immune system. And there's actually a tumor of this. It's called Merkel cell carcinoma. Now, this is not good because these are neuroendocrine cells. So if this was the lung, what cancer would this be similar to? It's a neuroendocrine cell tumor. What would this be in the lung? Well, it's a neuroendocrine cell of the lung. Anybody remember this one? Yeah, you guys remember. It wasn't that far away, right? Yeah, the Kolchitsky cell, these like Kolchitsky cells. So if they turn malignant, it'll look like a lung cancer called small cell, which is a tumor of the Kolchitsky cells. Yep. So when you get Merkel cell carcinoma, it looks just like small cell of the lung. You'll see these small round blue cells. It's going to stay with the neuroendocrine markers, the same kind of markers that you had in small cell. And do you remember the prognosis for small cell lung cancer? Okay, lung cancer is bad. Small cell was super bad. Same thing for Merkel cell. It looks just like lung cancer. It's a very aggressive tumor of the skin. It spreads and it kills you. In fact, whenever I get a biopsy of the skin and I look and it looks like small cells, I'm like, oh my God, is this metastatic lung cancer to the skin? Or is this a Merkel cell tumor? That's my big differential. So I always ask them, hey, is there anything going on lung? Can you do a lung scan just to make sure the lungs are clear? Because it looks like small cell of the lung that spread to the skin. So we always have to rule out a lung cancer before we call it Merkel cell. So that's a very cool tumor. And again, the board likes the tumors. They like melanomas, they like Merkel cell, they like squamous cell, they like basal cell. They like to talk about tumors. All right, now we got one more component of the skin, which, by the way, I forgot to mention. We talked about the epidermis. What about the dermis? Well, we've got two components of the dermis. We've got the dermis that goes up into the skin. See the way it goes up, it undulates up? That is called a dermal papillae. Dermal papillae, dermal papillae, dermal papillae, where the dermis goes up into the epidermis. So I told you, there's a whole new language we have to learn. So these are called dermal papillae. I'll just put P. Dermal papillae, dermal papillae, dermal papillae. So we call this the papillary dermis. This area right under the epidermis, we call it the papillary dermis. Now, deep to that, we have what's called the reticular dermis, reticular. The reticular dermis has got a lot of collagen. It's very dense and very strong. Okay, so two layers to the dermis. The papillary dermis, where the dermis basically goes up into the epidermis. They call it papillary dermis or dermal papillae. And then deep to that, you have much more dense collagen. That's the reticular dermis. Now, in the dermis, you'll see certain structures. For instance, you'll see hair follicles. So coming down, these are called adnexal structures, adnexa. So we'll see hair follicles that will come down here, come down like this. That's a nice hair follicle. And then, of course, attached to them is usually sebaceous glands. You got these sebaceous glands attached to it to create a little sebum, to create a little oil. And that oil will go, not only coat the hair, but it will coat the surface of the skin to make your skin kind of watertight. Yes, that's what we need that oil for. All right, now in addition, we can have sweat glands. And those will basically go through the epidermis, come down into the dermis, and then they kind of spiral. They spiral, they coil, they coil, they coil, they coil, they coil. So they kind of spiral down here. Those are your sweat glands. And of course, sweat glands is important for temperature regulation, right? Temperature regulation. So hair follicles, well, why we need hair, I forgot to mention. To keep us warm. Your brain has a tremendous amount of blood flow. So if you didn't have hair, you'd lose a lot of heat through your scalp. So that's why your mom always said, you're going out in the cold, wear a hat. Wear a hat to protect you from heat loss. So we have a natural hat, it's called hair, and then we can put another hat on top of it to prevent heat loss when it gets very cold in the winter. Yeah, you need that extra thing. Now it's also kind of protective. The hair is protective because if you get hit on the hair, it's got to hurt the hair. It's got to cut the hair first before it can cut your scalp. Now it's not a very thick protective layer, but you'll take any protection you can get, right? Now, if the hair was made of steel, you'd be wearing a helmet. That would be awesome. You'd have a helmet, a built-in helmet. So it's a little protective, so if you get hit with like a knife or something, you'd have to cut the hair before you cut the skin. So it gives a tiny layer of protection. It also keeps us warm. Now, where else do we have a lot of blood flow? Where else, from time to time, can you have a lot of blood flow? Oh yeah, so there's often hair down there too. And then of course your armpits. If your hands get cold, your mom says put them under your armpits, right? Armpits gonna have a lot of hair because a lot of blood flow there as well. So these areas that we want to prevent heat loss are the areas we're gonna have a lot of hair. I know, the butt too, what's up with that? I know, weird. But these are areas we can have heat loss. So these are just some of the easy components of the skin, nothing difficult here. Now what's difficult is the terminology. Dermatologists like to use all these fancy terms. That way they get paid, baby. They get paid because they got fancy words that the rest of us physicians don't use. They have microscopic terminology for lesions they see, and then of course there's microscopic. So let's just mention a few of these. Okay, excoriation is just a non-specific term for any traumatic linear break in the epidermis. So if you get scraped in a linear fashion or you get cut in a linear fashion, excoriation. It's non-specific, it's just trauma to the skin. Now this is an important one, lichenification. Lichen, thickening, it's thick, rough skin. That's the term, lichenification, thick, rough skin. So like if you're working out and you get these callus here, it's getting thick like a callus, that's lichenification of the skin, it's getting thick. Now it can also become scaly. It's when it's dry, plaque-like, plate-like excrescences start flaking off. That's scale. You've seen fish, you've seen snakes. They get they shed their skin scaly. Now here's an interesting term. Oncholysis. Lysis means to break apart, right? Lyse, to break apart. Yeah, this is separation of the nail plate from the nail bed. So basically your nail is falling off. That's the term. See, you could have just said nail falling off, but you don't get paid. Oncholysis, that gets paid. Wow, that's a big term. All right, now the most important ones for you to learn are these. The difference between a macule, a papule, a plaque, and then the difference between a pustule, a vesicle, and a wheal. So we need to learn what these things mean. Macule, papule, and plaque are used all the time. Now what the heck is a macule? It's flat. It's a lesion that's flat. So a macule is something that's circumscribed, but it's flat, and it's relatively small. It's less than 5 millimeters. Now, what if they say it's bigger than 5 millimeters? Oh, well then you just turn the word to patch. It becomes a patch then. So size matters. So if it's small and flat, you call it a macule. Macule. If it's big and flat, you call it a patch. Wow, fancy words. Now, what if it's not flat? It's elevated. Oh, it's elevated like a bump? You can't call it a bump, you call it a papule. So these are elevated, dome-shaped, or it could be flat top like a plateau. That can happen too. But it's elevated. It's not flat anymore. It's elevated. So it's either round or flat like a plateau. That's called the papule. And again, it's got to be less than 5 millimeters. If it's bigger than that, you change it to nodule. So papules, when they get bigger, they become nodules. So flat versus elevated. All right, now what's a plaque? Well, a plaque is when it's elevated, but very flat top and large. So it's kind of like a nodule that's kind of flat. So a nodule would be big and be around like that. A plaque is like elevated, like a plateau. That's a plaque. So very large, but it's elevated and kind of flat. That's a plaque. All right, now what's the difference between a pustule, a vesicle, and a wheal? Pustule, well, pus is neutrophil. So it's a pus-filled raised lesion. Yeah, a pustule. It's like, you've seen acne, the whitehead, and you squeeze it and pus comes out. Yeah, that whitehead would be a great example of a pustule. Yeah, it's white, it's raised, and it's full of pus. If you squeeze it, pus will come out. Now, a vesicle has clear fluid fill. So again, it's a raised, fluid-filled, not pus-filled, raised lesion. And again, they always use this 5 millimeter cutoff. So if it's less than 5 millimeter, you call it a vesicle. A classic example would be herpes, or maybe chickenpox. You get these vesicles, these raised fluid-filled lesions. Now, if it gets larger than 5, then you start calling it a boa. Now, lay people usually call it blisters. Oh, I got a blister. That's a vesicle. It's just a $10 word, right? Oh, people are writing stuff I didn't even look. Let me see what you guys are saying here. Let me look this up so I can see it. Does immune modulation have anything to do with shingles, or is that, yes, exactly. Justin's got it. Immune regulation, when your immune system drops, that's when shingles comes out. Shingles, if you've had chickenpox, it's hiding inside you. We don't clear it, it hides inside you because the herpes family has nuclear envelope, so we can't see it. Our immune system can't kill it, so it becomes latent in our ganglia. Now, you can live your whole life with it and never have reactivation. When does it reactivate? Well, when your immune system drops. Like if you get really stressed, if you get older and sick, whenever you get sick or stressed, that's when it comes out. Same thing with a cold sore. Cold sores come out when you get stressed, when you're taking an exam, when you have a hot date, when you get sunlight, when there's some sort of stress, that's what brings it out. Very good. Is air still fluid filled? No, that would not be called a vesicle. There's no medical term for that because we don't usually see air filled. We call it subcutaneous emphysema. If there's air inside the soft tissues, subcutaneous emphysema. So that's the term for air in the tissues, which is very unusual. Don't usually see that. You'll see it maybe with, Clostridium, like gas gangrene, Clostridium. You will see air in the tissues. And you'll see it when like organs rupture and air gets in this, like the esophagus ruptures, air in the mediastinum, air in the tissues. We call it subcutaneous emphysema. I like it. There's a lot of terminology to learn here. All right, now, what would you call it? If it wasn't like a fluid-filled area, what if it was, the dermis was edematous? There was edema, so it swelled up, got big, but it wasn't like you can't pop it and have fluid come out. It's just swollen. Well, that's what we call a wheal. It's itchy, it's transient, comes for a little while, and then it goes away. It's an elevated lesion that's really dermal edema. It's edema of the dermis. So again, it's not a fluid-filled blister or vesicle. It is literally edema of the dermis. It's swollen. Now, it's often going to be red. It's going to be red. So we call this a flare, the redness, and wheal. Flare and wheal reaction. And we'll see this a lot with allergic reactions. That's why it's itchy. It's very itchy because it's usually a type 1 hypersensitivity. So flare and wheal, you'll see this with allergies. When they eat like something they're not supposed to eat, like peanuts, they'll get this flare and wheal. Very classic for allergic reactions. Now this is dermal edema, wheals, dermal edema. What would you call it if the epidermis has an edema? Well, that's a microscopic term. Under the microscope, we call it spongiosis. Spongiosis when there's edema of the epidermis. Spongiosis. So let's go to the next table. Let's talk about some of those microscopic terms. And again, is the board going to ask me, what does this thing mean? No, but if I don't know what these words mean, I won't know what they're talking about, right? So we got to learn the terminology to be able to converse with the dermatologist and with exam questions. Okay, microscopic terms. What's the name for the epidermis is falling apart? The desmosomes are broken, they're falling apart, they're not sticking. Well, lysis of the epidermis. We call it acantholysis. Acantholysis, this is an important term to know. Acanthite, loss of cohesion. So what's holding the keratinocytes, the squamous cells, together? What holds them together? Desmosomes. So we're going to be talking about an autoimmune disease that attacks desmosomes. It's called pemphigus. Pemphigus is going to actually destroy the desmosomes, so the epidermis is going to fall apart. It's literally going to fall apart, and you're going to get blisters inside the epidermic. You'll get these fluid-filled spaces because all the keratinocytes break apart, and it's an empty fluid-filled space. So acantholysis, epidermis falling apart. You can also see it with scalded skin syndrome or toxic epidermal necrolysis. There'll be a couple of diseases that have this. All right, now dys means abnormal. Keratosis means keratin production. So this is abnormal or premature keratin of the cells below the granulosum. Remember, the granulosum is where those hyaline keratin granules start occurring. They start to come together, and then you get the cornea layer, right? So if it happens earlier, like you have keratinization before that, that's abnormal. Dyskeratosis, you're having too much keratin production too early in the epidermal process. So it's too low. Again, not a super high yield. So if you want to miss this one, I'm okay with it. But this one you need to know, parakeratosis. This is when the keratin layer, the cornea layer, still has nuclei. What? In the stratum corneum, the corneal layer, you shouldn't see, the nuclei should be gone. The cell should be very pink, very pink. So if you still see nuclei in the corneal layer, we call that parakeratosis. And this is going to be frequently seen in a disease called psoriasis. Psoriasis, the epidermis is proliferating, so it gets really thick, and it produces a lot of keratin. And you're going to still see nuclei, so it'll be abnormal keratin, it'll be parakeratosis. So it makes keratin that still has nuclei. So that's a very important term. You definitely need to know that, particularly for psoriasis. Now, hypergranulosis. That means the granule layer is really, really thick. So granule layer is really thick. The stratum granulosa is really thick. This is usually a sign of chronic irritation. So whenever there's a chronic inflammatory or a chronic irritation to the skin, you'll see hypergranulosis. So I just use it as a clue. Whenever I see it, I know the lesion's chronic. I know it's chronic. It's not acute. Okay, thickening of the keratin layer, or the granular layer, I should say. How about hyperkeratosis? Well, hyperkeratosis means thickening of the cornea layer. So lots and lots of keratin. And again, we'll see this one in psoriasis too. So this and this will be seen in psoriasis. So you'll see lots of keratin with still has nuclei. And then the corneal layer will get thicker and thicker, and you'll get what's called scales. Silvery, like white scales. And silvery scales, that's a classic description of a psoriasis plaque. A plaque with silvery scales. That's from all the hyperproduction of keratin. All right, now lentiginous. What does it mean, lentiginous? It means linear. Linear proliferation, usually of melanocytes. So when I say there's a lentigo or lentiginous growth, it means there's a linear proliferation of melanocytes, meaning they're proliferating along the dermal epidermal border. So one should be here, one should be here. If this one starts proliferating and it just keeps growing along the junction, that will be a lentigo or a lentiginous growth, linear proliferation along that line. Now, here's a very important term. I'm putting checks next to the ones you better know. You better know acantholysis, the skin's falling apart, epidermis is falling apart. Parakeratosis, where you still see nuclei. Hyperkeratosis, where there's just too much keratin, you get thick skin. And then acanthosis. Acanthosis means very thick skin. This is hyperplasia. Another feature of psoriasis. Psoriasis is very thick skin. It's like plaques. It's like plaque. Acanthosis. And I always think, like, thick-skinned. Maybe this is what Kim Kardashian has. She's got thick skin, right? People talk about her. Oh, she did a sex tape. Oh, she married Kane. Oh, she did this. Doesn't bother her. She's got acanthosis. She has thick skin. So people talk bad about you. Develop some thick skin. You'll be in good shape. All right, now what is papillomatosis? Well, this is hyperplasia, an enlargement of the dermal papillae. So in other words, these papillae that go up, imagine they go up like this. Whoa, whoa. That would be called papillomatosis, when you get big dermal papillae. Not very high yield. Erosion, simple term. Erosion means we disrupt the skin and we lose some of the epidermis. Not all of it, some of it. So like I scrape you, take off some of the layers, some of the stratum of the epidermis. That's called an erosion. What if it's all gone? Well, if I scrape all the epidermis off and maybe some dermis too, that's called an ulceration. Okay, so part of the skin, erosion. The entire epidermal surface and some dermis too, that's an ulceration. All right, now exocytosis, $10 word for inflammation in the epidermis. Now there should always be 1 or 2 lymphocytes surveilling. But when you start seeing an increased number, that is inflammation, that is exocytosis. All right, here's an important term, hydropic swelling, ballooning. This is when you're having edema inside the squamous epithelial cell. So this cell is literally swelling up. It's swelling. It should have been flat like this and pink, and now it's all swollen. That is a swollen cell. Now, what if there's edema in between the cells? In between them? That is called spongiosis, edema of the epidermis. So what you'll see is the keratinocytes will start to separate. Instead of being next to each other like this, they should all be next to each other. It should be one next to the other, next to the other, should be all next to each other. You're going to see them start to separate because there's fluid in between them. There's fluid in between them now. So you see all this separation in between the cells? That is called spongiosis. You'll see a lot of white spaces in between the epithelial cells. And then finally, vacuolization. Well, that makes sense. That's just inside the cell, there's a vacuole, a white space inside the cell. That's vacuolization. So we have edema inside the cell, we have vacuoles inside the cell, and then we have spongiosis, which is between the cells. All right, $10 words. Let's get to the fun stuff, man. Give me the diseases, bro. All right, now let's get to the fun stuff. I'm gonna show you some skin lesions. We're gonna start with the pigmented lesions first. Then we'll do all the other epidermal and dermal lesions. The first one is called Michael Jackson's disease. Do you remember what Michael Jackson had? He really had vitiligo. He really had it. At the autopsy, they confirmed it. He has vitiligo. Yeah, now what is vitiligo? Well, it's patchy loss of pigmentation. You're basically losing pigment of the skin in a patchy distribution. So this is an African American. Notice they've lost the pigment. Now this skin looks very, very pale. Obviously, this is going to be a cosmetic issue. People are going to look at you like, whoa, you look weird, dude. People are going to walk, they're going to talk, they're going to think you're, if it was the old days, they would think you're like a witch and stuff, and they would burn you at the stake. Seriously. So these people, it's a cosmetic issue. It doesn't really hurt you, but it's a cosmetic issue. Now, we think it's probably autoimmune. Autoimmune. Now, who do you get your immune system from? Your parents. So that means, is Michael Jackson's children at risk? What is it, Pillow and Blossom and Prince? Are they at risk? Are they at risk? His kids? Yeah, because you get your immune system from your parents. So if they really are his kids, they'll be at risk for this as well. Doesn't mean they're going to get it, but it means they're at risk because immune systems run in the family. You pass your HLAs onto your kids. Now, it affects all races. It doesn't matter if you're black or white. It doesn't matter. But if you're pale like me, like vampire pale, oh, you thought Twilight was a new movie? It's based on a true story. I sparkle in the sun. I'm so pale. If I got it, you'd never notice if I lost pigment until I tried to tan. So that's what you're going to look for. On the exam, they're going to say they go out in the sun, everything tans, but one area stays pale. That's vitiligo. Now, if you're darker skinned like Michael was originally, you're going to notice it. You're going to notice it. So when you notice it, you look funny. So what do? You cover it up. You start wearing longer sleeves. You wear shirts that are more like this. You try to cover up. Now, what did he do when it was on his hand? He started wearing a glove on one hand. Do you think he woke up in the morning and said, I'm going to make one glove cool? No, he said, I got vitiligo on this hand. How am I going to cover it up and make it cool? Well, I'll put a glove on, I'll put sparkles and sequins, and I'll make it cool. I'll pretend it's cool. Yeah, that's where the glove on one hand came from. He was trying to cover up vitiligo. Now, when it occurs on places you can't cover up, what are you going to do now? Well, usually what people do is if you lose pigment, they'll put makeup. They'll put makeup on it to darken it, to make it match the rest of the skin. In fact, there was an American top model contestant. She was an American top model. Every time she had to do a photo shoot, she would have to put on the makeup and match it and make all the skin look uniform before her pictures. So that's what people do. They usually cover it up. What did Michael do? He said, well, this is going to turn pale. I'm going to turn everything pale to match it. He hired doctors who came in with bleaching agents, and they literally bleached his skin. So he was like an albino on purpose. He was paler than you and me because he basically got rid of all the pigment. So that's why when you saw him outside, he always had an umbrella or a hat or a scarf. Or one time I went to the zoo in a burqa. Why was it a burqa? Because without melanocytes, you're going to get skin cancer. Yeah, so that's why he always covered up, because he was an albino on purpose. Wow. All right, now what if I looked at this area with a biopsy? What would I see if I looked at it with a biopsy? Well, you'd see absence of monocytes because the T cells, we think it's a type 4 sensitivity, the T cells came in and killed them. So the monocytes are gone. In albinos have monocytes. They just have no pigment. That's a big difference. There's no monocytes here. And of course, when do autoimmune diseases start? They usually are common in women, usually in the reproductive years, and that's usually when vitiligo starts too. So it certainly probably is an autoimmune disease. All right, now let's talk about too much pigment. That was loss of pigment, let's talk about too much pigment. Pigmented skin lesions. Now here's the rule. If you see a pigmented lesion, what don't you want to miss? Think about this. What don't you want to miss? Doctor, I got this pigmented lesion. If I miss a freckle, is anybody going to die? No. If I miss a lentigo, is anybody going to die? No. If I miss a mole, is anybody going to die? If you miss a melanoma, people die. So this is what I want to teach you. Because I know most likely you're not going to be a dermatologist, although you should consider it because they get paid like bang. But if you're going to be primary care, family practice, internal medicine, pediatrician, people are going to come in and say, doctor, what is this thing on my skin? You're primary care. They're going to see you and they're going to ask you what it is. So you know you're not a dermatologist. You should know when should I refer them and when should I reassure them, saying it's just a freckle, it's just a lentigo, it's just a mole. When should I refer? Well, first rule is if you don't know, refer. Be safe. You don't want to miss melanoma. But at the same time, you should at least know the basics. So here's the rule. Every time I see a pigmented lesion, I go through the ABCDs of melanoma, because I don't want to miss a melanoma. A, B, C, D, E. So let me draw melanoma for you. Let me draw one for you. Here it is. Here it is. Okay, there's a melanoma. Okay, number one, what are the features? Well, first of all, if you cut it in half, is it symmetrical? Not really. It's kind of like thicker here and here it's really thin. It's not quite symmetrical. It's kind of asymmetrical. That's one of the key features. Look for asymmetry. Asymmetry. So melanoma is asymmetrical, and I spelled it wrong. But anyway, I tried. Next is B. A, B, C, D, E's. Letter B. B is for borders. What about the borders? Irregular. Irregular borders. Notice the way they go in and out and in and out. They're very irregular borders. Now C. C is for color. What about the color? A black color? No, 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 no. A varying color. A variegation, varied color. If one area is dark black and one area is light brown and one area is red, I'm very worried. If it's all dark black, completely the same, uniform, I'm not worried at all. Not worried at all. As soon as I think it's a dark lesion, no. It's different colors. That is worrisome. So A, B, C, D, E. These are the features we're looking for. Now D. D is for diameter. Yeah, bigger the lesion is, the worse I'm worried. Now the key cutoff is usually 6 millimeters. What if I don't have a ruler, bro? You got a pencil? The eraser on a pencil, the eraser is 6 millimeters. So if I don't have a ruler, I just take a pencil and I put it on the lesion. If it's bigger than the pencil, the end of the pencil, the eraser, Well, then it's bigger than 6 millimeters. That's a quick and easy. The eraser is 6 millimeters. But use a ruler. When they're big, I get worried. Question, can a benign lesion violate one or two of these? Sure. But if you see more than one, you've got to consider excising it for melanoma. Now, here's the most important thing to ask the patient. Evolution. Evolution. Is it changing? If it's changing, yeah, doc, that's why I'm here. It's different. It wasn't this way 2 months ago. That's the most worrisome thing. Evolution is changing. The size is changing. The shape is changing. The colors are changing. It's elevating. It's getting raised. These are the things that make me the most worried. So you tell me there's a pigmented lesion that's changing, I say derm referral. Make sense? I want to err on the side of safety. Okay, so these are the things I want you to run through when we go through these pigmented lesions. Now the first one is completely benign. It is called freckles, but you wish. They're never going to call it freckles on an exam. Everyone would know what you're talking about, and they would pay you. So we call it ephelids. Because then the patient's like, I have ephelids? Okay, let me pay you. What is that? It's freckles. Oh, but I paid you. Shucks. You've all seen freckles. These are small, notice, small, 1, 2, 3, 4, a few millimeters, but less than 6 mostly. So they're small. They're tan red. They're light brown. So either tan red or light brown, there's usually one color, and they're macules. They're flat, they're not elevated, they're kind of nice and well circumscribed. Now, they usually occur after sun exposure. So what happens in the summer? When we see a lot of sun, they get dark. What happens in the winter when we're inside studying all day? Well, then they fade. So that's the key. They change with the seasons. That's the key thing in the history to look for, to tell me, oh yeah, that's definitely freckles. Darker in the summer, lighter in the winter, they change with the amount of sun exposure. Now, you usually don't, based on the appearance and the history that they get darker in the summer, you don't usually need a biopsy. But if you did, board question, what does a freckle look like? Is it more melanocytes? No, it's the same number. It's the normal number of melanocytes, but because of the sun, they make more pigment in that area. They just make more pigment. Now let me draw it for you. Let me draw it. Let me draw it down here. Here's the epidermal layer. Here is the epidermal-dermal junction. So epidermis, deep to that will be the dermis. The dermis will be down here. Now we're supposed to see melanocyte, then a melanocyte. They should be skipped around here. Okay, so it should be scattered around. Now, in this area, if the sun hits it and this melanocyte just gets revved up for whatever reason, and it makes too much pigment, well then this area, when seen from above, when you look from the top of the skin down, it will look like an oval, light brown macule. See, it's oval, nice and round, well demarcated, light brown or tan red. It's beautiful, small, okay? But again, same number of monocytes, that just making more pigment. And these are more common in people that are light-skinned. So people like blondes and redheads, they're most likely to get freckles if you have fairer skin. All right, now, what would you call it if I literally saw a proliferation, if I saw more melanocytes? Notice they're staying at the junction, so they're behaving, they're normal. They're just too many, they're proliferating. Well, that would be called a hyperplasia or lentigo. Lentigo, a linear hyperplasia, like a line. Lentigo's like a line. This is benign, localized hyperplasia of the melanocytes. It can involve mucous membranes and skin. So you can see in the skin, you can see in the mouth as well. Now again, they tend to be small, a little bigger than a freckle though. Notice, bigger than a freckle. They are oval, nicely circumscribed. They're tan brown macules or patches. Notice patches because they usually go for 5. So they're a little bit bigger than freckles, but they look a lot like a freckle. Now the key is, they don't change with the seasons. Once you have hyperplasia, you'll always have hyperplasia. It's not going to go away just because you have no sun. So it doesn't darken in the sun exposed, like when you have the summer. They don't get dark. So that's a key history difference. Changes with the seasons, freckles. Doesn't change with the seasons, lentigo. Lentigo also tends to be a little bigger. Now, under the microscope, the key feature here is you have more melanocytes, but they're linear hyperplasia, they're in a line. Now again, if I look at this lesion from above, it will look similar. It looks similar to a freckle. So it'll be an oval, light brown macule, and maybe a little bit larger in most cases. So again, these are things that you have to distinguish. Even though if you thought it was a freckle, nobody's gonna die. It's hyperplasia, no big deal. Now, what would we call it if I saw proliferation of monocytes like this? Notice, they're not behaving anymore. They're not staying on the junction anymore. Well, this is a tumor. This is a tumor of monocytes. Now, if it's malignant, you call it a melanoma. If it's benign, you call it a nevus or a mole. So that's what we'll talk about next. We'll talk about tumors, benign tumors and malignant tumors. For benign tumors, we call them nevi or nevus, if it's only one. So this is benign. Moles, people call them moles. So melanocytic nevi are called moles. These are benign tumors of melanocytes. Now, there's many different clinical and histologic types. There'll be a table coming up in a few minutes. We'll talk about the different types like Spitz nevus and blue nevi. So there's different subtypes. But one of the most common is called acquired nevi. In fact, everyone has it. Everyone has it. And the rule is you're not born with it. You come into this life with no nevi. Then you get sunlight, and because of the sunlight, everyone develops acquired nevi. So if you look on your arms, everyone's got it. Yeah, look at your arm. If you take a look, you will see these little light dots. See how round it is, round, small. That's benign. Everyone's got it. If you look around, you'll see there's more. Even darker skinned people have it. Everyone's got it. And the rule is, if you live long enough, they kind of go away. They become nerves. They drop down into the dermis and they kind of become nerves. So the rule is, my attending said, oh, remember, you're not born with nevi, you acquire them. So they're called acquired or nevocellular nevi, nevocellular nevi. And then you die without them too. You're born without them and you die without them. If you live a long life, they eventually will go away. Wow, cool. So acquired new nevi are the most common type, and they may become more prominent during pregnancy. So during pregnancy, they may really come out. They may darken, and you'll see them. So clearly, they are sensitive to hormones, okay? Because the hormonal changes can actually accentuate them. Now, what do they look like? Well, they're tan to brown. They're uniformly pigmented, so they don't look like a melanoma. They're well demarcated, round borders, so they don't have any of the features of melanoma. They tend to be small, usually less than 6 millimeters. They tend to be flat. Now, as they age, the cells drop down into the dermis and become nerves. As they drop down, the skin elevates. So when they get older, they become elevated papules. Okay, so it starts flat, and then over time it elevates as it becomes nerve. It neurotizes. It becomes nerves. Neurotization is what they call it. It becomes a nerve. All right, now let's take a look at the life and times of a nevus. Here's the life and times. Normally we should see monocyte at the dermal-epidermal junction. Now if we start to see proliferations, these are called nevi. Notice they're going above the junction now. So it's not a lentigo, because it's going above the junction. So this is called a junctional nevus. This is a tumor, but it's benign. Everyone's got them. So here's what happens. First, you're going to start with junctional nevi. Then these cells say, you know, we're from neural crest. We're monocytes. We're from neural crest. We want to become nerves. So they start dropping down into the dermis. When they drop down, and now you see nests down here. So I still have nests at the junction, but now I have intradermal nests. We now call it a compound nevus. Compound, because it's in both locations. Eventually, all these cells drop down. When they all drop down, notice there's no more junctional component. They all left, and they came down here. So this is called now an intradermal nevus. So it starts at the junction, then it starts dropping down, becomes compound, then it becomes intradermal nevus. Then the cells kind of like become spindle-shaped, like Schwann cells. They become like nerves. They become like nerves. And Schwann cells come from monocytes, it comes from neural crest, right? So melanocytes and Schwann cells both come from neurocrest. So basically it's turning into Schwann cells. See the way they're elongated now? So this is called neuritization. In fact, what's really cool is first they're going to have tyrosinase, right? Because they're making melanin. So tyrosinase, look at that, the pigment there, brown, they're brown, they're brown, they're brown, they're brown. And then they stop making tyrosinase and they start making cholinesterase. They literally become nerves. How cool is that? Wow. So Nicole wants to know, how do we tell a nevus from a lentigo? They both have proliferations, right? Location, location, location. So if we come back here, a lentigo has a proliferation at the junction only. Nothing's going up. Nothing's going up. Here we got the cells going up. They're going up. They're going up. That's not normal. Melanocytes should be at the junction normally. So that's how we tell a lentigo, which has a hyperplasia at the junction, a linear, right along that basal membrane, linear hyperplasia, versus a tumor, where it's going up. It's not following the rules anymore. It's misbehaving. Okay, Nicole, does that make sense? That's how we tell them apart. Yeah, I like it. This is what we need to do as doctors. How do we tell this one from that one? Now, as a pathologist, you're going to need to know clinically, what does it look like, right? But as a pathologist, that's what we look for under the microscope. Yeah, looking at the skin, it can be difficult. It can be difficult to tell a lentigo from a nevus. If you really want to know, you'd biopsy them. Now, do we usually biopsy nevi? You're going to biopsy all your nevi. If you look at your arm, you got lots of them. No, we only biopsy them if they start changing. Because can a nevus give rise to a melanoma? Yeah, it's not common, but it can occur. So if a nevus, a mole, starts changing, that's one that we're going to send for excision. Same thing, if a lentigo starts changing, we should send that for excision as well. Make sense? Not you, you're perfect, of course. You have no moles whatsoever. All right, here's what they look like. And by the way, everyone's got these, everyone. Even Nicole has one. All right, take a look. They're small, they're well circumscribed, they're round, nice borders, cut it in half, it's very symmetrical. It's got all the nice features we expect. Now, under the microscope, what does it look like? Well, here's the squamous cells, the keratinocytes, and by the way, just so you can see, do you see this granular, this very blue-purple layer right here? This is the granular layer. And then above it, you see just pink above it. That's the corneum, the stratum corneum, or the corneal layer. Yeah, this top layer, that's just the dead squamous cells that have no nuclei anymore. So that's normal. We should have a little corneal layer. We should have a small granular layer. If the granular layer gets thick, think about chronic irritation. All right, now here's the spiny layer, and at the bottom it's kind of hard to see in this picture, but there should be darker cells towards the bottom. Harder to see because at the bottom, let me just draw the junction for you. This is the dermal epidermal junction. Draw it for you. Okay, so this is the papillary dermis coming up. And then notice, these areas here are much lighter. Aren't they much lighter? This area is much lighter than the rest of the squamous epithelium because these are melanocytes. This is the junctional nevus. Here's another nest of these melanocytes right there. Here's another nest of these melanocytes. See that? They're like a big ball of melanocytes. Here would be another one. Ball of melanocytes. But it's at the junction. So this is called a junctional nevus. Now if you notice in the dermis, there's a couple of inflammatory cells here. So maybe they were scratching it because there's some inflammatory cells coming in. Now over time, these are going to drop down into the dermis. When they do, notice it starts to raise. See that? It starts to become raised now. It's not flat anymore. It's not a macule. It's now a papule. It's now an elevated mole. Now if we take a look, I think you can see all these purple dots down here. Oh man, these are all the nevi cells. And they're kind of like, it's hard to see, but they're kind of spindling. They're getting like thinner. They're becoming nerves. Here they are. All of this in here. These are all these blue dots in here. These are all melanocytes dropping down. Now, is there a junctional component? Let's go up to the epidermis. Oh yeah, do you see this pigmented area here? That's a junctional component. At the junction, there's another junctional component. There's another junctional component. So this would be called a compound nevus. Compound, because I see it at the junction and I see it at the dermis. This is both, so they call it compound. Now eventually these junctional areas will disappear. They'll disappear as they drop down, and then that will be just purely an intradermal nevus. Okay, so this one is a junctional, this one is a compound, because it's in both areas. Okay, now these are very common. Some people call them beauty marks. Beauty marks, right? Do you know who called her beauty mark? The supermodel, Cindy Crawford. Do you remember she had one right there? Do you see it? Or I just gave her another one. Just let me erase. I just gave her another one. Let me erase what I gave her. Okay, that's better. There it goes. So she had it right here. And as a kid, she actually wanted to have her signature mole. That was her signature. You guys that you know the original supermodel, or the original Cindy Crawford. I know she's 50 now, but she's still a 10. By the way, the original supermodel, Cindy Crawford, it's her signature. Whenever you saw that, you knew it was Cindy Crawford, right? It's her signature mole. She wanted to have it removed because the boys at her school football team were taunting her. They would scream, "Hey, little Crawford, you have chocolate on your face." And her sisters used to tease her about it, calling it her ugly mark. I guess it's like the ugly duckling. She turned into the beautiful swan. And her mother said, don't. Surgery is not a good idea. It may scar you. And then her career would be over. Yeah, those poor football players, they must be kicking themselves. What was I doing? They threw away a supermodel. I teased them. Oh, I know. That's the the story of the ugly duckling turns into the swan. All right, now what about genetics? Because this is a tumor. It's a benign tumor, but it's still a tumor. So what are the genetics of NEMA? There's got to be a gene if it's a tumor. Well, there is. There's activating mutations, so this must be growth pathway, right? Activating growth. Activating mutations in the BRAF gene. BRAF. Yeah, BRAF for short. BRAF gene. Yeah, this is a growth gene. This is part of the RAS pathway for growth. So it's part of the RAS pathway. So most commonly, you have mutations activating RAF, particularly at position 600. They call it a V600E activating mutation. Now let's explain. V is valine. That's what should be at position, amino acid position 600 in the BRAF gene. It changes, it gets replaced, it gets substituted by E, which is glutamic acid. So glutamic acid takes over position 600, and that's what turns on BRAF. So now this growth signal is going to come into the cell, and these melanocytes are going to grow faster. They have a growth advantage. That's why they're a tumor. They're evolved. They have more growth advantage than other cells, so they're going to proliferate. Now, BRAF is the most common mutation, but if BRAF is normal, then you can also have mutations in RAS. RAS mutations can cause it too. It's less common. Okay, so mutations in the BRAF or RAS signaling pathway are found in not only nevi, but they're also found in melanoma too. The same mutation is found in melanoma. So pretty important to know that. Okay, so this is found in more than one tumor. It's found in these benign nevi, and it's also found in melanoma. Now, there's a limited time of proliferation. In other words, the monocytes proliferate, and then they stop. Why? Why don't they just keep going? Why do they proliferate for a limited time and then they stop? Because a break. There's a break that activates. So we get oncogene-induced senescence. Oncogene-induced senescence. So basically, there's accumulation of a break called P16, also known as INK4A. P16. Now, if we remember, P16 is a minor break on the cell cycle. So it's a potent inhibitor of cyclin-dependent kinases, which stops the cell from growing. So let's repeat. They get this BRAF mutation, so the monocytes start proliferating, and then after time, the break kicks in and stops the growth. That's why they stop growing, they start dropping down, and they say, all right, I'll become a nerve instead since I can't grow. Now, what if you knock out the break? If I knock out this too, now I'm going to get melanoma. So notice, this break is often disrupted in melanoma. and like dysplastic nevi too. So if they lose the break, the nevus will start becoming dysplastic, and then eventually could become a melanoma. Interesting, huh? And by the way, are there families who have mutations in P16, like it runs in their family? Yeah, that's a familial cancer syndrome called familial melanoma. If you're born with a knockout of this break, well, in your life, if somebody causes a BRAF mutation, you're not going to get a nevi, you're going to get a melanoma. You have a higher risk. So that's familial melanoma syndromes. So for your brain, you better have both these genes in your brain. You better have BRAF because there's going to be a drug that's going to inhibit it. It's going to be a drug that inhibits it for melanoma. And then you better know P16 because P16 is good for a nevus, it stops the nevus, but it gets knocked out when you get melanomas. So pretty important to know the genes for melanomas. All right, now, benign or malignant, doctor, go through the ABCDEs. Patient comes in, they show you this lesion. Okay, symmetrical, let's see. Oh yeah, this side, when you cut it in half, one side looks like the other side, that is symmetrical. How about the borders? Pretty good, looks nice and regular to me. Borders look good. How about the color? It's really dark. Yeah, but it's uniform. As long as it's uniform, I'm happy. Now, what about size? Let's see, 6 millimeters. 1, 2, 3, 4, 5, 6. 6 millimeters would be like around here, 6 millimeters. Okay, so it's pretty big. So that's a little worrisome. It's more than 6 millimeters. But again, benign lesions can dilate 1, right? Then you ask them the most important question. Is it changing? No, doc. I was born with it. I've had it my whole life. Everyone makes fun of me. That's why I want it removed. I just can't take it anymore. It's right on my face. People hate it. Yeah, this is called a congenital nevus. Benign. You're born with it. We call it congenital. Now, do I worry about congenital nevi? Well, you're born with it as long as it stays the same. And by the way, some people call these birthmarks because you're born with it. Birthmarks. My dad's got one right here on his forehead. His whole life he had it on his forehead. And I was like, Dad, why don't you remove it? He goes, well, it's my signature now. Everyone knows me by it. Okay, cool. So for some people it's bothersome and they want it removed. For other people, they kind of like it. So do I worry about these? Well, I do if they're giant. When they're giant, I'm worried. For instance, look when this kid's born. What's the parents going to say? Oh my God, you can't see that on ultrasound? When this kid's born, they have no idea. They take a look like, my kid's deformed. Oh my God. Yeah, they call this a bathing suit nevus. Do you see what they call it? It looks like they're wearing a bathing suit, but they're naked. This is a nevus. It's all kind of hair on it. It's very hairy. It looks like a Wookiee. Looks like a Wookiee. My kid's half Wookiee. Yeah. Actually, if you said that, the dad would be okay. Okay, cool. The mom would be like, what? Dad would be like, yeah. Yeah, this is called a bathing suit nevus because it's in the distribution of the bathing suit. So this is kind of scary. First of all, you have to reassure the parents because they're going to be freaking out. They're going to, my kid's deformed. No, it's just a birthmark. It's a giant congenital nevus. Now, I'm worried about these because over time they could turn malignant. So am I going to try to excise this whole thing? No, you'll need a skin graft from hell. No, what we're going to do is we're going to take pictures and then we're going to do frequent follow-up. We're going to have them back every year, look at the old pictures, compare it to new, take new pictures, and if any part starts changing, what if this area started growing? Well, then I have to resect that area because it may be transforming to melanoma. Got it? So the significance of congenital nevi is we just watch them. If they're giant, they have a risk of turning to melanoma. So we have to watch them, and if they change, we'll try to excise that area. But excising a giant one like this is going to be almost impossible. Look at the skin graft you need. Where are you going to get all that skin from? It would be difficult. So we can resect parts of it and try to prevent any areas that's transforming. All right, now here's a table. Here's a table of some of the variants of nevi. We talked about acquired. Then we're talking about congenital nevi. These are nevi that are kind of dark, deep dermal, so they tend to be very dark. They often have a lot of hair growth on them too. They can have they grow out in nexoglands and structures, so they can make the hair grow. They're identical to an acquired nevi. They're present at birth. That's the only difference. They're present at birth, so we call these birthmarks. And the significance is since they're so large, there's a chance that they can turn to melanoma. Not a big chance, but there's a small chance, so we have to watch them. And again, just put the other names, so remember we call these birthmarks. You can call them Wookiee marks now if you want. I love it. So we call these birthmarks. And that's what Cindy Crawford was born with. She was born with a congenital nevus right here. Congenital birthmark. All right, now blue nevus. Guess what it looks like? It looks blue, black. So black and blue. It looks blue-black. So it's, here it is. It's got very heavy pigment to it. So it's very dark. It's very blackish blue. Blackish blue. So tell me, what is it going to look like if it's very dark and bluish black, the color's a little bit changing? It's going to look a lot like a melanoma because the pigment is so dark and it's kind of variable. It's blue and black, blue and black. So that's the problem with it. Some people think it's a melanoma. Then you'll excise it and they'll say, no, it's just a blue nevus. The pigment was funny because it was a blue nevus. Okay, so that's the significance. It looks like a melanoma, so a lot of people wind up resecting them. Comes back as a blue nevus, you're like, you're safe. Wasn't melanoma. Now, how about this one? A spindle or epithelioid cell nevus. Now, spindle means the cells are really elongated. So the melanocytes are really elongated, or they could be epithelioid, which means they're fatter, more like an epithelial cell. So they're big and plump, or they elongated and spindle-like. So the melanocytes are looking a little different here. This is called a Spitz nevus, so spindled or Spitz nevus. Now the key for this one is, again, they could be large plump cells with pink cytoplasm, or they could be elongated fusiform like spindle cells. But the key for this one is they look red-pink. Red-pink. So look at this. Oops, let me erase this for you. Take a look at this. Does that look pigmented to you? Does it look like a nevus? It looks like a blood vessel tumor. It looks like a hemangioma. That's the significance of a Spitz nevus. They often confuse it with hemangiomas because it looks like blood. It looks like blood vessels, right? All right, now what about a halo nevus? Not from the game Halo. No, this is when your immune system comes in to attack these benign tumor cells. And therefore, you'll see the pigmented lesion in the middle, but around the edges it starts clearing. The pigment gets destroyed. You destroy all the cells. So lymphocytes infiltrate the edges, and they start clearing it. They start basically killing the nevus cells because they recognize them as abnormal. Okay? Now this is basically an acquired nevus that your immune system starts attacking. So you got this host immune response against it. So here's what it looks like. See it? Isn't it cool? So cool. So here is a nevus. This person has 2 nevi. Here's a new one, a nice acquired nevi. And then this one, the immune system is clearing around it. So it's not just killing the nevus, but it's also killing some of your pigment as well. So this is kind of like vitiligo. Vitiligo around the nevus. Vitiligo, the immune system is actually attacking it. By the way, this can also happen with melanomas. Sometimes your immune system will kick in and try to start clearing the melanoma. So you can see clearing around melanomas as well. So that's the significance. When I see a halo nevus, I'm saying, is that a nevus that the immune system is attacking, or is it a melanoma? So again, we go through the A, B, C, D, E's. Now this one's a little bit irregular here. Notice the board was kind of irregular. So that's a little concerning. The size looks pretty small of a ruler here, but size looks okay. But it is getting a little irregular. So some people will excise these, halo nevi. But again, they're totally benign. Now, this is an important one. Please take a look at this picture. Do you like this lesion? Not really. I don't really like this one, right? I don't like this one, right? Yeah, because it's got, the borders are getting irregular, but the pigment variation. It's darker here, it's lighter here, it's like reddish here, it's brownish here, it's blackish here, it's dark black here, it's red here. I don't like this one. Now in terms of millimeters, 1, 2, 3, 4, 5, 6, it's large. But the most important thing is if I say, Doc, that's why I'm here. I don't like this, it's changing. You say, I don't like it either, I think it's melanoma. So what do you do? What do you do? That's right. When in doubt, cut it out. When in doubt, cut it out. So we're going to do what's called an excisional biopsy here. We're going to try to get around it with some decent margins. Now, if it turns out to be melanoma, we'll come back and get bigger margins. But the key is I don't want to cut through these. If I cut through it and it's melanoma, you could spread it. So we try not to cut through the things that might be melanoma. We do an ellipse of skin around it, try to get around it with good margins. Now again, if it turns out to be melanoma, we want to get about a centimeter around it. So we'll come back and we'll take another ellipse. Make sense? If it turns out to be melanoma. But we'll take out a small ellipse around it, get it out, and then if it's melanoma, we'll come back. Now this report comes back as dysplastic nevus. Well, that's a nevus that's getting funny looking because it's getting atypical features. It's taking on the features of melanoma. In other words, it's on its way. It's starting to transform to melanoma. So again, most melanomas happen de novo. They happen by themselves. But sometimes you have nevi that become dysplastic and become melanoma as well. So this is a potential precursor. And there's a couple things I want to tell you, and we'll take a break here. Some people call dysplastic nevi BK moles. I guess for Burger King, dysplastic Burger King, I don't know. Another name for it's an atypical mole, a mole that looks funny. Now, like all of these lesions, they occur in sun-exposed areas, but notice they can also occur in non-sun-exposed areas, like your armpit. How much sun exposure does your armpit get? Do you walk outside with no shirt like this all day long? You don't. You're not supposed to see pigmented lesions in your armpit, at the bottom of your feet. If I see a lesion at the bottom of my foot doesn't get much sun. I'm always thinking, oh, could it be melanoma? That's a weird spot. So funny things occur in areas that don't get sun. What about in the vulva? How much sun does your vulva? Oh, don't tell me, because who knows, maybe you're a nude sunbather. But not too much sun in the vulva. So when I see things in the vulva area, I start thinking, is it dysplastic? Is it melanoma? I start thinking about weird things. Now, the vast majority are stable. They don't progress, but they can. So a small number of these dysplastic lesions will turn to melanoma. But of course, not every melanoma comes from dysplastic nevi. A lot of them arise de novo. Melanomas usually just happen by themselves. But a small number can occur from a dysplastic nevi. So these are a marker that is a risk of melanoma. Now, they could be sporadic or it could be familial. So always take a look and see how many you have. So if it's sporadic and it's over 10, well, you're at high risk, right? If it's familial, you're going to have hundreds. We call that the dysplastic nevus syndrome. You get hundreds of these nevi. It's usually autosomal dominant, and your chance of getting a melanoma is virtually 100%. So here's the rule. If there's 10 or more, sporadically, or if there's hundreds like dysplastic nevus syndrome, you must have the patient come in and say, get naked, dude. Get naked. Because you want to take pictures of the body, you want to remove the most worrisome, and then have them back in 6 months to a year and take more pictures, and anything that changes, you want to take them out. I can't resect hundreds of nevi. I could take out 10, I'll take out the 10 worst ones, and then I'll have you back in 6 months, look at the pictures, see what's changed, take those 10 more out, and if I keep doing that, I can prevent melanoma. Because if I don't follow these patients aggressively, virtually 100% will get melanoma. Make sense? Now again, the good news is, when I resect this bad boy, this thing is out. This thing can't become melanoma, but there might be more. So when you hear dysplastic nevus, you say, get naked. See, this is why you should become a dermatologist. Because you tell everybody, get naked, I'm going to take pictures of you. In fact, I'm going to take pictures of you every year. You go to the club saying, hey, I'm a dermatologist. You need to get naked for me. I don't think it'll work, but yeah, everybody gets naked for you. You can take pictures of them. So pretty cool field to go into. But I'm serious about this. You got to take pictures and look for changes, and then keep removing the ones that change and look like they're going on to melanoma. If you do that, you'll prevent them from getting tumors. Because take a look here. Look at this guy. Boom, 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 boom. How are you going to resect all of this? I mean, it's going to be virtually impossible. So we're going to resect the ones that look the worst. We'll resect the ones that look the worst. Resect this one. Take out the ones that look the worst. Take pictures of everything else, and then have them back. Now, how are we going to recognize these dysplastic nevi? Well, the size. They're kind of larger and more irregular than acquired nevi, so they're usually over 5. They have variegation in pigment. Variegation in pigment. In fact, they often describe them like targets. So if we take a look here, notice the way the center is darker, and the edges are lighter. So it kind of looks like a bullseye or a target. Center is darker, and the edges are, it almost looks like a halo, right? Almost looks like a halo nevus. If it lost the pigment here, it was lost the pigment, would be like a halo. Now the borders are irregular. They're usually flat maculas, but they can become bumpy on the surface, a little pebbly surface, but they're irregular. Under the microscope, they're taking on atypical features. Architecture is weird, cytologically they're weird, they're taking on features. And of course, it's got the same activating mutations as every other melanoma, but they can also have P16 knockout too. That's why they can be on their way to melanoma. Now, melanoma is the first 5-star thing in this chapter. So it's perfect time to take a break. When we come back, we'll attack melanomas. Okay? All right, Kevin wants to know, what would be the opposite of a halo nevus? Something that was pale in the center and darker on the edges? Well, if it was a rash, you'd call it a bullseye rash of maybe Lyme's disease. Lyme's disease has central clearing with a red border around it. So Lyme's looks like target. Another thing that looks like target rash would be erythema multiforme. They look like targets or bullseyes. But again, those are rashes. They're not really black, brown pigmented lesions. So there's nothing more pigmented lesion that I know of that's pale in the middle and darker on the edges. I just don't know of any. Yeah, I don't know of any lesion that would be like that. I would have to say probably a funny looking melanoma. It's a melanoma going in a circle. So melanoma going around in a circle, so the center's still clear, but it's going around in a circle. But I don't know of any pigmented lesions that look that way. I like it. I like it. I'm going through all my files in my brain, and I can't think of anything. And maybe an autistic melanoma. So instead of spreading across, it spreads around, and then it comes back on itself. Maybe that's what it is. Because this one, maybe this is like clear kind of in the middle, and dark kind of at the edges. Maybe. I don't know. Use your imagination a little. All right, let's take a break. I'll see you guys in a few minutes. Okay, gang, here we go. Hour number 2. Let me start the recorder. Skin path number 2. Okay, second hour, we got the 5-star topic, melanoma, to cover. It's irregular, it's large, it has got pigment variation, and if you notice in this area, notice the way the light is shining off it, because it's elevating. Now that's bad, because if a melanoma is going up, that means it's going deep, it's going vertical. And vertical growth, the deeper it goes, the more likely it is to find a blood vessel and metastasize. So when they raise, we call them nodular melanomas, and that's bad. Nodular ones are the ones that are likely to spread, because vertical growth going deep. Now let's talk more about melanomas. Notice, it's only 10% of all skin cancers, but it counts for 90% of all skin cancer deaths. So it's not a common skin cancer, but man, it is a common killer in terms of skin cancers. It's a baddie. Now, it's increasing in epidemic. It's like an epidemic. Your generation's getting the suntan early, you're getting LeBrons, you have the sun tanning boots, and you wind up with melanomas at a young age. Now, a risk factor is clearly sun exposure, because UV ultraviolet light induces DNA damage. So our body's got to repair that, or eventually mutations will accumulate and you get cancer. Now, where in the world are there a bunch of Caucasians living near the equator with great sharks? Down under. So you'll see a lot of skin cancer in Australians because these are Caucasians living by the equator. So yes, you're in my favorite Wolverine, Hugh Jackman. Yeah, he's got skin cancer. He's got it like 3 times on his nose. He had basal cell. We'll talk about that in a minute. Basal cell is one of the most common of the malignant skin tumors, and he's had 3 of them on his nose already. Classic Australian. Now, who's going to get more damage from sunlight? People that have less pigment. So fair-skinned individuals, so blondes, brunettes, anybody who's got fair skin, sorry, blondes and redheads, I should have said. Blondes and redheads, they tend to have less pigment, and they get more burns. Now, the key is intensity. The intensity of the exposure. It's not the cumulative lifetime exposure as much as it is short, intense damages. So sunburns. Sunburns as a kid. That is a big risk factor. Now, I want you to focus on risk factors. Students are telling me, John, they're asking risk factors. What's the risk factor for Alzheimer's? What's the risk factor for this? They're asking risk factors because they know you're memorizing all the particular details about the disease. So they want to know, do you know the risk factors now of a lot of different disorders? So sunburns as a kid is a big one. So now you don't know what I'm talking about because in the summer, you stayed inside and played Nintendo. But before Nintendo existed, actually when I was a kid, there was Nintendo, we just couldn't afford it. So we had what's called backyards. We had backyards. In the summer, Mom would say, get out and don't come back until dinner. So we'd be outside all day and we'd get sunburns. So when you have sunburns as a kid, later on in life, your risk of melanoma is much, much greater than somebody who's never gotten any sunburns. So very important for your kids, let them go outside, but get some sunscreen on them, protect them. Now, there's also hereditary predisposition. Some people have a higher risk of getting melanoma hereditarily. And one of the couple of reasons is, number one, a genetic disease called xeroderma pigmentosa. This is autosomal recessive, and you're missing the enzymes that repair DNA thymine dimers. Remember, sunlight causes thymine dimers, makes them stick together. We have to excise them. We need the excision endonuclease system. Well, if you have genetic mutations in the excision endonuclease system, that's called xeroderma pigmentosa. These are called the children of the night. Why are they called the children of the night? Because they can't see sun. If they see the sunlight, they will get skin cancer because they can't fix thymine dimers. So it's kind of like the witness protection program. You keep them inside, you black out all the windows. When you take them to school, you put a jacket over them. Quick, get them in the car. Quick, get them in the car. At school, quick, get them in school. Get them in school. Cover up the windows. It's like witness protection. You're like hiding from the sun. They call them the children of the night. They go outside at night because sunlight will cause skin cancer. And they get all skin cancers. They get basal cell, they get squamous cell, and eventually they get a melanoma. So the reason they call it pigmentosa, because they get pigmented lesions. Eventually, one of them turns out to be melanoma, and that's what can kill you. Melanomas kill. The other skin cancers don't kill as much. This one kills. Now, you can also have familial melanomas. We talked about it. It's kind of rare, but there are families that have high rates of melanoma, and that's because that family has a mutation in the CDKN2A gene, which codes for P16. P16 is just another name for the gene, P16 gene. Now, this is a tumor suppressor gene. It's an inhibitor of the cell cycle, so it's a break. It's a minor break. P53 is the major break in the cell cycle. This is a minor break. Well, if you're driving around, your car is missing the emergency brake. Well, man, most of the time you're okay. You got the regular brakes, you're okay. But if there's an emergency, you don't have the emergency brake, you got a higher risk of crashing, a higher risk of getting melanoma. So your family's got a big risk because you're missing this minor brake. Now, we talked about dysplastic Nevus syndrome, virtually 100% risk of melanoma if they're not followed and resected whenever there's atypical lesions. So follow them very closely. Now, gross appearance, we talked about it. There's usually no symptoms. That's why they're so dangerous. In fact, a couple of the reality show guys got diagnosed because the viewers are watching the show and they notice this thing on their face or on their neck, and they send them a letter saying, hey, that thing on your neck, it's weird. I see it every time and I'm concerned. And sure enough, the reality guys go to the doc and they say, oh, that's a melanoma. You saved my life. You know, one of the flipping shows, I forget which guy it was, but one of the flipping shows, they actually diagnosed them because the viewer sent them a letter of concern. Wow. So watching reality TV shows can save lives. That's what you tell yourself when you're watching them. I'm trying to save lives. All right, now most are asymptomatic, so that's always concerning. Unless you notice the lesion, they can keep growing and growing. So we look for ABCDEs. We look for asymmetry, we look for irregular borders, variation in color, diameter greater than a pencil eraser, which is 6 millimeters. But the most important thing, I'll put all these asterisks here, because this is the critical lesion. If you tell me a pigmented lesion is changing, I'm very worried. I want to take a good look at it. I want to get a derm consult. I want to consider excising it. Whenever I see a change in the appearance, a change in the color, a change in the size, elevation, such changing, I'm worried. Now, other features that make me concerned as well, if you start seeing hypopigmentation. Oh, remember we talked about the immune system coming in, attacking it? Yeah, so I start seeing it losing pigment all of a sudden. That could mean that the immune system recognizes melanoma and is coming in to attack it. So again, when we say halo nevi, unless it looks really nice and bland, we sometimes excise them because we think it may be melanoma with the immune system responding. Now, another worrisome thing is if you have a pigmented lesion that starts itching or is painful. Moles should not hurt. Moles should not be itchy. My moles never bother me. So if moles start hurting you, that's when it may not be a mole. So itching, ulcerating, painful, these are very concerning findings in a pigmented lesion. All right, now when I see something ugly like this, I want to do a wide local excision. Again, I don't want to cut like this because I just cut through it. So now I can potentially spread it. When you cut through a tumor, you can sometimes spread it into vessels. So I want to get a wide excision around this. And again, I don't want to cut through it. That would actually not be good. I still cut through it. So I can't, the picture, I got to go around the picture. Make sure you get a nice around it. Now again, for melanoma, we'd like to have a centimeter, 1 centimeter margin. Now on the face, I may not, if it's next to your eye, there's not enough skin there. So I try to get a centimeter if possible around it. Try to. Now again, if you have to take less, you can take less. When it turns out to be melanoma, you got to go back and take another ellipse, take another piece to make sure that you didn't leave any tumor cells. All right, now under the microscope, what are we seeing here? Well, I think you can see this basal layer here. You see a lot of white spaces, right? These are the melanocytes. You see these nests here, they're going up. They're going up, white spaces. Here's some more melanocytes. Look at these over here. These spaces here, these are the melanocytes. Here they're with pigment. See the pigment? So let me just outline. These are some nests of melanocytes. So it's going way up in the skin, way up there. And these cells are cytologically, if you get closer, they'll be looking ugly. And then notice down here in the dermis, we see an inflammatory infiltrate. The immune system recognizes this is not good. So melanomas usually have this band-shaped infiltrate of lymphocytes. They're coming in to try to attack these cells. Unfortunately, they don't usually clear it. See, the immune system recognizes it ain't good, but for some reason it doesn't clear it. We've got to get the immune system. Let's help the immune system. Let's turn on the immune system, because can the immune system kill melanoma? Yeah, you saw vitiligo. Immune cells know how to kill melanocytes. They're just not. Do you see the inflammation? Why are you not killing them? You're coming in. Why are you not killing them? So one of the treatments now is immune therapy. We're trying to get the immune system to attack. We'll get interleukin-2 to turn on T cells, interferons. We'll use these cell checkpoint inhibitors to try to get these lymphocytes to proliferate. Try to get them to stop going to apoptosis and get up there and kill. That's what we want. So we're trying to use the immune system to fight it, because chemo doesn't work very good for melanoma. So we want targeted therapy and immune therapy. Very important. Now, if we take a look at this picture, I think you can see the epidermis here. Epidermis. And then deep to that, see these nests down here? This thing is invaded. It's invaded. Here it is. Look at it. These nests of invasion. So this thing is going deep. See all the pigment it's making? Making pigment down there? These are all tumor cells making pigment. Now there's a couple of malignant cells here still in the epidermis here. Got some epidermal tumor cells too. But this stuff is now invaded. And that's the key. If it's still in the epidermis, I'll cure everybody. As long as it's going across the skin horizontally, yeah, just keep growing across, dude. Just let the cell grow across, fine. I can cure you. But once you go deep, you're going to find blood vessels and metastasize. Yeah, so this is not good. Now, if we look a little closer, look at these ugly nests of cells. So there's a nucleolus in that one, chromonucleolus. Look how dark and hyperchromatic this one is. That's a giant nucleus. That thing is a big old ugly-looking monocyte. So these atypical, ugly-looking monocytes invading. They make a lot of pigment too. Now, it's going to spread first to the regional nodes. Wherever this is in my skin, there's going to be a draining node. To find it, we'll inject dye here. So if we excise it, that's melanoma, we'll come back to the incision site and I'll inject dye. Then wherever the dye goes to, I'll take out that first node the dye goes to. That's called the sentinel lymph node. Sentinel. So the first lymph node that it drains to, that's the one we take out. And again, we can inject dye, or we can actually inject radioactive, use a Geiger counter to see which node it goes to, and excise that node. That's called the sentinel node. Now, in the sentinel node, if there's large tissue chunks, no problems, I'll see it. What if there's microscopic cells? Hard to see. So one of the stains we can use for melanoma is HMB45. It will stain the tumor wherever it is. If it's in your skin, it will light it up. Here's a lymph node. These are all lymphocytes here. And then notice this little nest of like 2 or 3 tumor cells. Just 2 or 3 cells. We can pick up micrometastasis in the lymph node by doing the HMB45 stain. So very helpful. I was over human melanoma black. That's the name of the stain. Human melanoma black. Or you can, ladies, you can remember H&M. The shopping store, H&M. H&M, it's Black Friday. Black Friday, it's 45% off. So H&M, 45% off on Black Friday. Melanoma. Yeah, cool. Yeah, sunscreen is very effective. We want to use sunscreen. But again, you can still get burned. If you go in the water, you wash off the sunscreen. After time, you sweat, the sunscreen comes off. So we have to keep reapplying the sunscreen to protect us. Yeah, you know, we're supposed to get 15 minutes of sun a day. Did you know that, to make vitamin D and be healthy? 15 minutes. Do you get 15 minutes of sun a day? John, I'm in the library. I'm in class. I'm home reading my books. I'll see the sun when I go from my house to my car, from my car to the school, from the library at home. You're supposed to get 15 minutes of sun. Now again, if you're going to be out for longer periods, we definitely want to have sunscreen on because it's very effective at protecting us, but we have to keep reapplying it and make sure we cover the areas. Because sometimes we're like, oh yeah, I put it here, but I didn't put it here. Well, guess what? The areas you don't cover, the sun's going to find. So again, great stain here, HMB45, great stain for diagnosing melanoma and for looking for metastasis. Now you can also use S100 because it's neurocrest. So S100 is another stain you can use as well. HMB is a little bit more specific. All right, now let's talk about how this thing grows. It first grows across the epidermis. So it grows across first. So it grows across first. And then eventually, one of the clones will start to go down. When it starts going down into the dermis, now it can find a blood vessel because the blood vessels are down here in the dermis area. So once it finds a blood vessel, now it can actually metastasize by using that blood vessel. It can spread through it to the rest of the body. So first it's called radial growth, also known as horizontal spread. This is horizontal growth, growing across. Now, as long as it's growing across, it doesn't have the ability to metastasize because there's no blood vessels in the epidermis. The epidermis doesn't have blood vessels. Only the dermis does. So the good news is, as long as it's growing across, you're cool. And it's often associated with a host lymphocytic response. So you'll see all these lymphocytes down here just growing across with it, just growing across and saying, hey, don't you dare invade, don't you dare, I'm waiting here for you. So our immune system is trying to keep it at bay. Eventually, though, there'll be a clone that says, forget that, I'm invading. And that's called vertical growth. It's downward growth. This is going to create, first of all, a nodular appearance to the tumor. Because as it goes deeper, it's going to push up and you'll get a nodule. And of course, this is a clone that will eventually get metastatic potential, find a vessel, and invade. This is called tumor progression. It's evolution of tumor. First, the tumor grows across, it's not behaving. Then it says, you know what, I'm going to bust through the basement membrane and break free. So you get a clone that makes collagenates. Now it breaks through, comes out here, then another clone says, I'm going to metastasize. So it goes to the blood vessel, busts through the blood vessel, gets in the bloodstream, and starts floating away. And then if the clone has tropism, it will find an organ that it likes, bind to it, and invade and start growing there. So a lot has to happen for a tumor to metastasize. You got to pick up a lot of different mutations to give it abilities to grow and invade and then grow somewhere new and make new vessels. All right, now outcome. We always want to know how I'm going to do, doc. How I'm going to do, doc. Staging. Staging is your number one prognostic feature. Now, what does the T stand for? Tumor size and depth. So part of the TNM staging is the depth. Now, how do you measure depth? With a ruler. When I take the biopsy out, I'm going to measure from the granular cell layer, which will be up here somewhere, towards the top, the granular cell layer. I'm going to measure from the granular cell layer down to see how deep is it going. Is it going that deep? Is it going this deep? How deep? Exactly how many millimeters is it going down? So I measure from this granular layer down to the tumor to see how thick it is. So that's called Breslow's thickness. This is one of the most important things for prognosis of the patient, because the deeper it goes, the more likely it is to spread and have positive nodes and have positive metastasis. So for TNM staging, the T is determined by how deep it is. Now, here's the number I want you to get in your brain. A Breslow's thickness of 1 millimeter. Now, that's not very thick. 1 millimeter is like paper thin. It's like paper thin. That's a millimeter. It's like paper thin. It doesn't have to go very deep to metastasize. So I want you to have a Breslow's thickness. When it's greater than a millimeter, it has the potential to spread. If it's less than a millimeter, just excise it, you're cured. It can't spread. But once it's greater than a millimeter thick, which is not very thick, it has the potential to metastasize. The probability of metastasis correlates with the depth. When it's over a millimeter, it has the potential to spread. Okay, so very important. Now, if it is greater than a millimeter, it can spread. So we should take out the sentinel lymph node. The lymph node, the N, that's part of the TNM staging system, will tell me if it's spread. So again, here's the rule. First, you excise the tumor with nice margins under the microscope. If it's deeper than a millimeter, Now you order a sentinel node biopsy. You go back to the patient, bring them in, put the dye, see where it goes, take out that node. Now, if that node is negative, see, sentinel node means first node it's going to drain to. So here's the first node it's going to drain to, and there's other nodes behind it, but it's going to drain to this node first. Well, if this node is clear, what does that tell about all the nodes after it? Well, they're going to be clear too, because this is the first node that drains that area. So this is the sentinel. This is telling me, is it involved or not? If it's involved, that means it's probably everywhere. If it's involved, you should check the other nodes, and you should give adjuvant therapy. You should give immune therapy, you should give targeted therapy, you might want to give chemotherapy, you might want to give radiation therapy, you want to use adjuvant. So primary therapy is excision of the tumor, then you take out a sentinel node. If it's positive, you add adjuvant therapy. So that sentinel node is important. So what was the number again? 1 millimeter. 1 millimeter, it's time. And again, how do we measure the thickness? We measure from the epidermal granular cell layer, that granular little blue dots, to the deepest point of tumor invasion. How deep did it go? Okay. Now, other things that are important are how many mitosis. The more mitosis, the faster it's growing. Presence of ulceration. If the surface is ulcerated, that's not a good finding. That's usually aggressive tumor. Presence of lymphatic response to tumor. That's a good prognosis. So if lymphocytes are coming in and they're attacking the tumor's starting to regress, that's good. Because that means the immune system, by being stimulated, it will probably help kill the tumor for us, because it's already starting to work. So having a little clearing of the tumor is actually a good finding. That's a positive prognostic feature. But overall, TNM staging is the key. Staging is the key. Now, there's different types of melanoma. We're going to go from the best one down to the worst one. The best one looks like a lentigo gone crazy. It looks like a freckle, like a lentigo. It looks like it went crazy. So we call it lentigo malignant melanoma. Another name for it, since it does look like a freckle, some people call it a Hutchinson's freckle. That's what some people call it. Hutchinson's freckle, because it looks a lot like a freckle gone crazy. Now, here's everything you need to know. It's on the face or neck of an old person. And it's got the best prognosis. Why? Because old people don't text each other. Old people talk to each other face to face. Hey, you know that thing on your face? It's changing. I don't like it. Yesterday was different. Today, you better get it. That thing on your face. They're going to talk to them, and they're going to see it. They're going to see it changing. See, you guys don't look at each other. You just text each other. You don't even talk to each other. You just text each other. Every once in a while, you'll send a naked picture. But use a filter. If you use a filter, I'm not going to see it because you're using a filter. So your generation's screwed. But older people talk to each other, they're going to see it, and they're going to resect it before it spreads. So that's why this one has the best prognosis, because we're going to see it early, and we're going to do something about it. Melanoma is about catching it early. If you catch it early, I can cure most of these. When you catch it late, it becomes a big nodule, and it spreads, and it kills you. Gotta catch it early. So this is the best one. Now, the most common, the one that you're going to see and you're going to diagnose in your practice, is called superficial spreading. It's the most common type. We call it superficial spreading because it's in the radial growth phase. It's growing across the surface. Now, the good news is, catch it early before it goes deep, you cure them. Now, if you catch it late, there'll be clones that go deep, and then it will spread, and you're in trouble. So the rule for melanoma is catch it early, you got cure. Catch it late, it kills you. And these are usually in the sun-exposed areas. Makes sense? So both of these sun-exposed. Now, acro means extremity. Extremity. Lentiginous means flat, like a lentigo. So we call it acrolentiginous melanoma. This is the one you're going to pick in darker-skinned individuals. Yeah, like for instance, do you remember the reggae man down in Jamaica man? Remember Bob Marley? Bob Marley got melanoma. Now where? Well, African Americans don't get melanoma. They got pigment to protect them from the sun. We don't get pigment? Palms, soles, and under your nails, subungual. Under the nails, subungual. So I want you to remember, acro means extremity. Palms, soles, and under the nails. Bob Marley's was under his toenail. That's where his was. So when you see darker skinned individuals, that's where it occurs. Now again, soles of my feet don't get much sun. That's not sun exposed area. So there must be another mutation. Yep, this is the one that has an additional mutation. Remember, all the ones have BRAF. BRAF part of the RAS pathway. But acrolentigis has its own mutation. Remember Bob Marley was from Jamaica? He's from the Caribbean? Well, there's a Caribbean island called St. Kitts. Yep, this one's got c-KIT mutation, just like St. Kitts. c-KIT mutation. Well, c-KIT is a tyrosine kinase. Oh. So, this is going to grow like crazy because you're going to activate c-KIT. If you turn on c-KIT, tyrosine kinases cause growth. So that's why this is a very aggressive one. And even though it's flat, it will metastasize and kill you. So even though it's lentiginous, it's flat, it will spread quickly and kill because it's got this mutation the other ones don't have. The other ones have BRAF, part of the RAS pathway. This is c-KIT different. Now, good news for these patients is it's very aggressive because of c-KIT, but we have a drug. Do you remember a tyrosine kinase inhibitor? The first one ever invented was for CML. Do you remember for CML? What was it called, the one for CML? Yeah, tyrosine kinase inhibitor, tyrosine kinase inhibitor. It was invented to block ABL. It was invented to block ABL. That's its job. Block the BCR-ABL fusion, right? ABL was causing CML to grow. But then we found out not only does it block the ABL tyrosine kinase, but it also blocks c-KIT too. Cool. So we invented it for CML because it blocks the ABL tyrosine kinase, CML. But now we can use it for any c-KIT tumor as well. Very good, Kevin. STI 571, that's the experimental name that they sometimes use on exams. Very good. Gleevec, another name. Yeah, Gleevec. Tyrosine kinase inhibitor, signal transduction inhibitor 571. Very good. Now, what they like to do is something evil. Everyone knows imatinib for CML. So what they'll do is they'll say a patient comes in, they're a new patient, they're on imatinib. What tumor do they have? And you're like, imatinib, CML, imatinib, CML. You look down the choices, no CML. Diarrhea. So remember, it was designed for CML because it blocks the ABL tyrosine kinase, but it also works for c-KIT tumors as well. So look for acrolentigus melanoma. There's another tumor that has c-KIT in the GI tract. Do you remember the stromal tumor? The tumor of Cajal cells or Cajal cells? Yeah, GI stromal tumors as well. So imatinib is a pretty cool drug designed for CML, but we can use it for acrolentiginoma and GI stromal tumors, the GISTs. Very good at it? Very good. You drew up big time. All right, so this is kind of a special one. It killed Bob Marley, by the way. It spread to his liver, it spread to his brain, and it killed him. Yeah, they should have used H&B 45. Diagnosis melanoma, keep Bob Marley alive. Yeah, all that stuff wasn't invented, so unfortunately he died. Now, the worst melanoma of all, so we went from the best one down to the worst one is called nodular. The worst one is called nodular because it's already going deep. It's already going deep. So when it goes deep, it goes up like a nodule. So most nodular melanomas have already spread. By the time you catch them as a nodule, they've already spread. So let's repeat, they start out flat, horizontal growth, then they start going deep and they become nodular. That's the problem with melanomas. They eventually become nodular. And when it's nodular, it's already gone deep. Sentinel nodes are usually positive. It's usually in other organs. The prognosis for metastatic melanoma is not very good. So we got to try to catch these before they spread. Very important. Very high yield topic. All right, now let's go back to the genes here. They love genetics. And I kind of like this picture because it explains a lot of the pathways. We've talked about P10 already for some of the GYN, like the prostate tumor, the thyroid tumors, the endocrine tumors. That was knocked out, and that was a break on growth. So that's why you get prostate, endometrial hyperplasia, endometrial cancer, and thyroid cancers, right? So we talked about some of this growth pathway. This is part of the RAF pathway. But RAS also works through BRAF, BRAF and MEK, BRAF and MEK. Another way to get proliferation. So this RAS pathway is pretty darn important. And that's why RAS mutations are very common in a lot of tumors. Okay, so growth factor should bind to a receptor, the receptor should bring the signal in, and then it tells RAS to do signal transduction, bring the signal in. And again, there's two major pathways RAS can use. Now for melanoma, we're going to talk about this pathway, the BRAF-MEK pathway. So most commonly, there's mutations in BRAF. So if I turn on BRAF, then I don't need a growth factor anymore. I don't need a growth factor. If you turn on BRAF, you'll get the growth signal transmitted in without any growth factor. So this melanocyte is now going to grow in an uncontrolled fashion. Make sense? Now, BRAF mutations, also RAS mutations also, but BRAF is the most common. Now, if this is what's causing the growth, activating mutations in BRAF, usually position 600, you get a V to E substitution. Well, if this is what's causing the tumor to grow, let's block it. Let's make a blocking drug. Now, BRAF is not a tyrosine kinase. So the drug that blocks it is not a TNIP, it's not a tyrosine kinase. It's a serine threonine kinase. So we call the name of the drug vemurafenib. Vemurafenib. Notice it's not a TNIP because BRAF is not a tyrosine kinase. It's a serine threonine kinase. So it's similar because it's a kinase, but you can't call it a tyrosine kinase inhibitor. You can't call it a TNIP. So they call it vemurafenib. Now, when I first saw that name, I was like, come on. I mean, I like Finib because it kind of sounds like a TNIP, but then I realized, ooh, it's a V to E. Look, V to E mutation, MU, mutation in RAF. There's RAF right in there. BRAF. RAF is in the name. So I like it. It stands for V to E mutation in RAF. And we can use it anytime there's a V600E mutation. That's why you need to know that mutation. This mutation activates RAF, and we got a drug for it. Now, this inhibitor works pretty good, but we also have another inhibitor of MEK, which is the next step. So we like to use both of these drugs together because they're kind of synergistic. It'll really shut this pathway down. So nowadays, we're using targeted therapy with vemurafenib and a MEK inhibitor. Well, we use them together. Now again, for boards, they're going to ask about the BRAF inhibitor, even though we use a MEK inhibitor with it. Makes it work better. But BRAF is the one they're going to ask about because other tumors have BRAF. If other tumors have it, they really like it because they can ask about other tumors using vemurafenib as well. Cool. All right. So activating mutations in BRAF or RAS pathway are very important. Now they can also have loss of function in PTEN. So just like prostate, just like endometrial, just like thyroid cancer, you can lose the brake here, and that can also cause growth as well. Now, for familial melanomas, they're the ones who have the loss in P16 already running in their family. So without P16 to break the cell cycle, well, now RB is not going to be a roadblock anymore. Remember, P53 enhances RB, so does P16. They both make RB stop the cell. So this is like a minor break. P53 is the major break. But again, you have a higher risk of melanoma. And then the acroliticious melanomas have activated mutations in c-KIT, which is a tyrosine kinase inhibitor, and we can use imatinib. So I know it's not sexy, but this is what the board loves. BRAF mutations, RAS pathway, P16, c-KIT. They love it. So let's make sure we pull this all together. What gene mutation is associated with the acrolitigenous form and only the acrolitigenous? c-KIT. So what drug can we use for c-KIT mutations? We use imatinib. They love it. Imatinib, because everyone thinks CML from imatinib, and you should. CML and imatinib, but there's another use for it. Now, what mutations can we find in most other melanomas? It's mutations in BRAF, particularly V600E mutations. So that's a very important one because if you have this mutation, we've got a drug for it. It's called V to E mutation in RAF, so we call it vemurafenib. They finally named the drug right. So it comes from V to E mutation in RAF. That's where it got its name. And again, they couldn't call it a TNIP. They couldn't call it a TNIP. They called it a FINIP because it's going to inhibit the kinase, but it's a serine threonine kinase. So they couldn't call it a TNIP. All right, now I want to add another thing to your notes here. I want to add another thing. These are called targeted therapy. In fact, in the future, when you have a tumor, we're going to take your tumor, see what's causing it to grow, and we're going to design drugs. Is it c-Kit? We'll block it. Is it BRAF? We'll block it. This is the future of medicine. This is sexy. If I'm writing exam questions, I'm like creaming. I'm like, oh, this is so good. Oh my God. You get so excited when you get targeted therapy. Because think about this. If I give you chemo, your hair falls out. If I give you targeted therapy, it's targeted. There's much less side effects. It's targeting your tumor. It's not killing a lot of other cells. So a lot less side effects with targeted therapy. Now, the other thing that's sexy about melanoma is we can also use the immune system. We can use the immune system. So I just want to add this. You can put this here on the margin here. I want to add a couple of drugs to your handout here, because if I'm writing questions, these are cool. Okay, now first of all, how do you turn on T cells? Interleukins. So giving interleukin-2 can turn on T cells. You can also turn on the immune system by using alpha interferon. So those make sense. We've used that for a long time. Alpha interferon for melanoma for a long time. Interleukin-2 for a long time. But the new sexy drugs are called checkpoint inhibitor drugs. Checkpoint inhibitor. Remember, lymphocytes are normal. They don't live forever. They don't proliferate forever. There's control on them. Well, when you have a tumor, we don't want them to undergo apoptosis. We don't want them to go into growth arrest. We want them to proliferate like crazy. We don't want our cells with checkpoint inhibition. We want to inhibit checkpoints. We want them to grow like crazy and attack the tumor. So we have two classes of drugs here. PD-1 inhibitors. PD stands for programmed death. I don't want my cells to die, so I want to inhibit the death of lymphocytes so that way they work better. So PD-1 inhibitors, and they got fancy names, they're monoclonal antibodies. PD-1 inhibitors, they basically prevent lymphocyte death, and it basically turns off lymphocytes. It turns them on. They don't die, they grow. Cool. And then another one, the CTLA-4 inhibitor. Now, if you remember back in the Wayback Machine to the immune diseases, the autoimmune diseases, a lot of autoimmune diseases occurred because they knocked out CTLA-4. CTLA-4 is supposed to inhibit T cells. That's a shot. Inhibit T cells. So what we're going to do is we're going to knock it out. We're going to knock it out so now the immune system can grow like crazy. Now, could this give me an autoimmune disease? Potentially, because we're kind of unleashing the immune system. So could it attack us some? Sure. Hey, but I'd rather have an autoimmune disease than a malignant cancer that's going to kill me. Remember, this is from metastatic melanoma, which is often a death sentence if you don't do anything. So, yeah, we're going to unleash the immune system. So these are hot. If I'm writing questions, I'm going to get hot and bothered over these immune therapies. So targeted therapy, love it. Imatinib, Vemurafenib, MEK inhibitors, but immune system. In fact, this is now being offered as first-line therapy for metastatic tumor. PD-1, programmed death inhibitors, because we don't want the lymphocytes. We don't want them to die, we want them to grow. Isn't that cool? You guys with me? Do you find that sexy too? Does that make you horny, baby? I know, I'm with you. I'm a pathologist because I don't do drugs. But these are kind of high yield. If I was going to write questions, I'd ask questions on this cool therapy. Oh yeah, Dr. Z, he just goes crazy on this stuff, man. His poor wife. Honey, you need to put me in the mood. Can you whisper these mabs to me? Can you imagine? All right, that's a thought I don't want to think. Never mind. Never mind. Then you go to the oncologist bedroom and it's like, honey, can you whisper staging systems to me, please? Oh boy. I don't want to go to the proctologist bedroom. I don't want to know what they do. But, oh my gosh. All right, so getting silly. Now, since I said BRAF is not unique just to melanoma, I want to memorize it all together. Give me a bunch of tumors that have the same BRAF V600E activating mutations, and therefore I can use Vemurafenib, the BRAF inhibitor, Vemurafenib. Well, we already talked about melanomas, right? So most melanomas, with the exception of acrolentigенous, but most melanomas, we can use BRAF inhibitors. Now, how about papilothyroid? Yeah, the papilothyroid, the one with the Sonoma bodies, the one with radiation exposure. Yeah, papilothyroid. Little papillary fingers here, little fingers. Yeah, papillary, but I'll be honest. Papillary cancer, we resect it, and we give radioactive iodine. You don't usually need a BRAF inhibitor, but it's still kind of cool. It's got BRAF. Now, hairy cell, 90% or more, 90% or more of hairy cells have BRAF mutations. Wow. Now, the drug of choice for hairy cell is cladribine. Remember, cladribine blocks 2-CDA. So, it's called 2-CDA. It blocks adenosine deaminase. That's what I meant. It blocks adenosine deaminase, and now deoxyadenosine accumulates and kills the hairy cell. Just like SCID. Just like SCID. SCID was missing adenosine deaminase. Well, for hairy cells, we're going to block it with cladribine. Well, if cladribine fails, you can use vemurafenib as a second-line drug. Yeah, so cladribine is your go-to drug, but you can now, if you have resistant refractory cases, you can use vemurafenib. Cool. Here's an important one. Skin tumor called Langerhans cell histiocytosis. This is a tumor of the histiocytes of your skin. Histiocytes. We talked about, what was his name? Rafael Nadal. He's at Wimbledon with his tennis racket. Do you remember the tennis racket inclusions? They kind of look like a tennis racket. They're called Burbeck granules. He is one ace. It's got CD1A. He is one ace away from winning Wimbledon. If only he can get his serve over 100 miles an hour. So that's pretty much everything you need to know about histiocytosis. It's got BRAF mutations, so we can use vemurafenib. It's got tennis racket Burbeck granules. He's 1A, CD1A is the CD number, but 1 ace away. And if you can get a serve over 100 miles an hour. Did we talk about this, right? Didn't we talk about this in the previous chapter? I'm pretty sure I showed you the picture of Raphael. Okay. Okay, because I was like, silence, radio silence. Maybe I didn't talk about it with them. They're like, what the hell is he talking about? Okay, so do you remember that one? And then some colon cancers, but also brain tumors like pilocytic astrocytomas. Pilo means hair, cytic cell, cells that look like hair. Pilocytic astrocytomas, this is a brain tumor that you see in children. Pilocytic astrocytomas. So man, there's a lot of tumors that are going to be BRAF. So might as well just learn some of them together. So here's the ones that you should know. You should definitely know melanoma for BRAF. Definitely know melanoma. You should definitely know hairy cell for BRAF. And you should definitely know Langerhans cell. So there's lots of other tumors, but those are the three biggies. Three biggies to know about BRAF. Cool. All right. By the way, here's the name of the drugs. We have vemurafenib. Notice the RAF in there. And then the newer one is called dabrafenib. It's almost like BRAF inhibitor, dabrafenib. It's dabraf. What's it against? dabraf. All right, sorry. I'm trying to get gangster, but I can't. I saw that Dr. Phil episode with that girl going, cash me outside, cash me outside. I have no idea what she was saying. They actually have to put like subtitles. I thought she was saying catch me outside, but no, it's cash me outside. Okay. How about that? Oh man. These kids think they're so gangster. All right, now, pigment lesions are done. Now we can do about lesions of the epithelium and the dermis. Epithelial and dermal lesions. Now I'm just going to do these because these are really simple. They're not very high yield, but you're going to see these. You're going to see these all the time. So first one's called a fibroepithelial polyp. I wonder what that polyp's made of. Is it made of fibrous core with an epithelial lining? Yeah, it's got a fibrous core. See how pink it is in the middle? See, here's the skin. Let me go across. Here's the skin. Here's the skin. There's the epidermis and the dermis. And then all of a sudden you have the big polyp. This big old polyp. This big old polyp. This big old polyp with a fibrous core and a nice epithelial surface. Benign, fibrous fibrous, fibroepithelial polyp. Another name for it is an acrocordone. That gets paid. A skin tag, that's what people usually call it, a skin tag, this little thing hanging off me. And if you look at it grossly, it looks like a little tiny polyp. It looks like a little polyp hanging off your skin. And people get it usually in the neck folds and the axilla. And they're going to come and say, no, what is this little thing hanging off here? What is this little polyp hanging off here? You say, oh, it's benign. I'll cut it off for you. Just cut it right off. Boom. So they're soft. They're flesh-colored. They look just like flesh. They're like a bag with a stalk. Now, what people do at home is they'll take a little piece of thread. They'll tie it around the base. Just tie it around the base. Tie it, squeeze it, just pull it. They just tie like a thread around it. And then the next day, since you cut off the blood supply by tying the base, they tie a little string around it, and the next day it undergoes necrosis, and in a couple of days it falls off. So we'll take a scalpel and just cut it off. But you can put a string around it and it'll fall off itself. Benign, but kind of like nasty looking, right? Little polyps hanging off your armpit or on your neck. So people like to take them off. Yeah, that's why you're going to see them all the time. Doc, I don't like this, take this off. Oh, fibroepithelial polyp, sure, done. And you get paid. It's a procedure. Yes. All right, now what about epithelial cysts? Well, this is just some epidermis or hair follicle epidermis that gets trapped in the dermis. That's all it is. So it's basically invagination of the epidermis or hair follicle epithelium, either one, that gets trapped. So either this epithelium got trapped down here, or maybe a hair follicle, some of the epithelium got trapped from the hair follicle. Yeah, that's all it is. It's just trapped. Now, obviously, it's going to make a lot of keratin, right? So you'll see a bunch of keratin debris in the middle. So nice lining. See this purple lining here? That's the squamous lining, just like the epithelium. It's exactly normal lining. But there's a lot of keratin debris in there. So lipid debris, keratin debris. Now, it's the epidermis that gets stuck. We call it an epidermal inclusion cyst. It's just a piece of epithelium, an inclusion of epithelium is included into the dermis. Now, if it's the hair follicle epithelium, we call it tricholemal cyst. Wow, I get paid for that one. Tricholemal cyst, what the heck is that? It's a benign hair follicle cyst, no big deal. Now, if you see a lot of them, you should consider a polyposis syndrome. And again, for board purposes, this is probably the most important thing on this page, Gardner syndrome, which is polyposis syndrome, plus fibromatosis of the abdomen, plus osteomas of the jaw, plus these inclusion cysts. And this stuff in the middle can be very cheesy. So if you ever squeeze them out, like if you break them to the skin, like cheese-like material will come out. So it's like Jennifer Gardner's movies, they were really cheesy. And you got like dead cells in there, they're like ghosts of girlfriends past. Gardner's, polyposis, she makes thousands of dollars making crappy movies. My crazy mnemonics, they come through every once in a while. All right, now is that sexy to you, doctor? Look at my armpit. There's no polyps, but it's thick and dark like leather. It's not sexy. Acanthosis means thick skin. Nigricans means dark. Thick, dark skin. Again, usually in the folds. It's usually in the neck folds, the axillary folds, and the groin folds. I'm glad they didn't show the groin. They showed the axilla, and they showed a little the neck there. It looks like it's getting dark in there too. Yeah, this is thick, hyperpigmented skin. Some people describe it as like velvety or like thick and like paper, sandpaper, and it's in the flexural areas, the fold areas. Now, the benign types, because it could be associated with malignancy too. The benign types, most of the time, I'd say like 95% of the time, it's associated with type 2 diabetes. Type 2 diabetes. Yep, type 2. So diabetes type 2. Now, who gets diabetes type 2? Well, obese patients do. Pregnant women do. Pregnant women do. Who else? Who else gets diabetes? How about polycystic ovarian syndrome? Yeah, they got diabetes. We're going to use metformin for them. Metformin. Try to control their sugar. If you control their sugar, they may even ovulate. It kind of gets everything back in line. So very important to remember, diabetes. Now the reason for diabetes is because of insulin-like growth factor. Insulin can cause growth. That's why if the mother is diabetic, you have big babies. macrosomia, the baby, because the insulin that the fetus makes, remember the mom's got the diabetes, when the sugar goes to the baby makes high levels of insulin, and the high levels of insulin can cause growth. So that's what we're thinking. We think it's diabetes because insulin-like growth factor is causing growth of the epidermis. Now, very rare, but there are hereditary forms where your family has that. Yikes. This is an autosomal dominant mutation in fibroblast growth factor. So again, growth factor. Usually insulin-like growth factor, but familial will have this fibroblast growth factor. All right, now I want to know about malignant. Only about 5% of the time, they will show this and they'll say, the sugar's perfect. There's no diabetes. And you're like, what? Brown said this is diabetes almost all the time. Diabetes. Pick type 2 diabetes. Type 2, not type 1, type 2. Type 2 diabetes. There's no diabetes? Oh, then it could be a paraneoplastic syndrome. It could be a paraneoplastic syndrome of an internal malignancy, because internal malignancies can make epidermal growth factors. They can make different growth factors that cause the epidermis to grow, particularly stomach cancer. Always check for stomach cancer. So when I see this, you're getting a scope above and a scope below. I'm looking for stomach cancer, pancreatic cancer, colon cancer. Stomach, colon, pancreas. If it's none of those, look for lung cancer, because lung cancer can make epidermal growth factors too. Okay, so GI and lung, paraneoplastic syndrome, all about 5%. Justin, I just saw a type 2 diabetic with the neck fold darker. There was a lot of skin tags. Yeah, skin tags is related with aging. So who gets type 2 diabetes? Older people. So that's what was related, that older people get skin tags, older people are more likely to get type 2 diabetes, right? The risk factor for type 2 is aging and weight. Aging, weight, and also genetics too. Yeah, good associations. And let me tell you, when you see stuff in the clinic, you own it forever. You own it forever. So I'm glad you're getting out in the clinic. I'm glad you guys are trying to take an active interest in learning, because that's what we call you residents. We call you residents because we want you to live in the hospital. We want you to live there. Because that way, if you see it, once you see it again, you'll never miss it. See, I'm trying to teach you all this stuff from a book, from pictures. But the real way you learn it is under fire on the wards. So I'm trying to prep you, because when you see it again, now it'll make sense. So you pull it all together. That's what Jerome was talking about. Oh, now I see it, now I know. And then you become a great doctor. And that's what I want from you guys. Remember, your destiny is greatness. Seriously, I hope you guys are hanging in there, because I know at this point in the course, people start like passing out. They start dropping over. Hang on, the light is at the end of the tunnel. But we only have like 2 months to go, right? March, April, and then May is finals. So you only got 2 months, that's it. 2 months to go to freedom of the wards. And let me tell you, it's so much more fun being on the wards than sitting in a classroom. So the light is at the end of the tunnel. You finally get to meet other people, walk around the hospital, wear that white coat with pride, get pimped like crazy, but at least you're learning your craft. You learn your craft. So much more exciting. All right, let's take another break. We're almost done with the day. See you guys in 5 minutes. See you in 5 minutes. Okay, gang, welcome back. We have about half an hour to go, so we're going to try to end on time so you guys can go study your pharmacology. Thanks again for sticking around and hanging out with me. I always like to have a live audience. Makes it a lot more fun than talking to myself. Sometimes I feel like I'm talking to myself anyway. I'm looking at my own picture and I feel like I'm all alone here. Kind of like being in a classroom where I can interact with you guys. Anyway, thanks for hanging out. All right, now let's move forward and talk about the next condition, which is very common. You are going to see this. In fact, you might get it yourself. You're going to see this as people get older. It's usually middle-aged and older individuals, and it's called a seborrheic keratosis. Now, this is a tumor, but a benign tumor. Benign tumor of your squamous epithelium. The dermatologist will shorten it. They'll call it a SEB-K. SEB-K. So when you do your derm rotations, it's a sub-K, a sub-K, a sub-K. And I'm like, what are you talking about? Seborrheic keratosis. Oh, benign squamoproliferative lesion. Benign tumor, benign, cosmetic issue only. Now, it's very common on the trunk, the neck, and the head. So it's usually face, neck, trunk. It could be on the extremities. It could be anywhere. The description is the giveaway. They will describe it as a coin-shaped exophytic, big old mass. Looks like a coin, the shape of a coin. And it's kind of granular and kind of dark, very granular and dark. But they usually describe it as a stuck-on appearance. It looks like it doesn't belong. You're like, excuse me, miss, please, I think you have a booger. Let me take that booger. Oh, it won't come off. It looks like it's stuck on the face. Doesn't this look like it doesn't belong? Looks like you can pick it off, doesn't it? That's how they describe it. The coin-shaped stuck-on lesion. Looks like it doesn't belong. Now, when I was younger, don't tell anybody, but we go in the bathroom of grade school, and we take the brown paper napkins, and we get them all wet, and then we throw them on the ceiling, and then later on they fall down on someone. Well, what does it look like? The brown paper thing stuck to the ceiling, and they call them a stuck-on lesion. Now, of course, I didn't do that. I said I saw other people doing that in the bathroom. Did I just admit this on tape? Never mind. All right, I owe the public schools some paper towels. Now, what are these granules here? Well, these granules are the opening for little cysts, little pseudocysts. They call them horn cysts, horn cysts. So if you take a look at this microscopic picture here, notice the epithelium is growing downward. See how it's growing downward? It's benign proliferation growing downward. All these cells are growing down. And then there's these cystic spaces. See them? Now they're called pseudocysts because they're open to the surface. You don't always see the connection in the planar section, but you can see this one's open to the surface, this one's open, and that's what gives it this granular appearance, these opening to these cysts, and this little light pink stuff here, this is all keratin. Keratin, so they call these all horn cysts, these keratin-filled pseudocysts. Now, if this is the tumor, again, it looks very granular like this, granular, kind of round to oval. If this is a tumor, it must be a gene. Yeah, it's the fibroblast growth factor receptor mutation again, causing this epidermis to grow. So we just saw this mutation twice. We saw it in the rare hereditary forms of acanthosis nigricans with the thick leather-like skin, and you can see it in these tumors as well. Later on, we'll talk about bone lesion that has knockout or loss of function of it. Actually, it's a gain of function where you turn this on and it fibroses the growth plate, and therefore your long bones are going to be short. You'll be very, it's going to be a form, the most common genetic form of dwarfism. It's going to be called achondroplasia. So it's going to be very important later on for the bone chapter as well. So activated mutations in achondroplasia, activated mutations in seborrheic keratosis, activated mutations in genetic forms of acanthosis nigricans. All right, so I try to keep these things together in my brain. All right, now again, is this going to kill you? No, it's benign. It never metastasizes. It's benign. It's totally benign. Now, people take it out because of cosmetic reasons. Everyone's looking at me funny. It looks funny, so cosmetic issue. They're going to take it out for cosmetic reasons. Sometimes they get infected. If they scratch it, it gets infected. We may take it out for that reason. But most of the time, it's just cosmetic. Now, what if suddenly they develop hundreds of them? Well, if you suddenly develop hundreds of these stuck-on lesions, that is a sign of internal malignancy. It gets a fancy name, the sign of Lesser Trilat. The sign of Lesser Trilat. Now I get emails. Bro, I was taking an exam, What the heck is the sign of Lestrade? Dude, that is the sudden appearance of hundreds of seborrheic keratosis over a short period of time, like over a month or so. You develop hundreds of these, and that's a paraneoplastic syndrome. It's telling me there's a carcinoma inside. Again, think GI and lung. Think GI and lung. Stomach cancer, colon cancer, pancreatic cancer, and lung cancer. It's got to be one of the tumors making growth factors, particularly transforming growth factor alpha. That's what seems to be responsible for stimulating the sudden growth of all these epithelial tumors. Okay, sign of Lestrade. So now I have two paraneoplastic skin lesions. We got the acanthosis nigricans. Again, when I see it, I think about diabetes. If they don't have diabetes, I worry about stomach cancer and lung cancer. Same thing here. When I see sudden development of hundreds of seborrheic keratosis, benign square proliferative lesions, I need to check the stomach and I gotta check the lung. Okay. All right, now super low yield. Adnexal tumor. Adnexal are the hair follicles, the sebaceous glands, the endocrine, the sweat glands. So these are tumors of the glands and hair follicles. Now, they're very low yield. But if I don't tell you about it, then when you're a clinician and you send a biopsy and it comes back with it, you're like, what is this? Bruno never told me about this. I feel like a dummy. So again, for the boards, these are pretty low yield. But if you've never heard of it, I would be embarrassed. So tumors of sebaceous glands. They're called sebaceous adenomas. Sebaceous adenomas. You'll see lobular proliferation of sebocytes. Sebocytes. And notice what they got. They got this foamy cytoplasm. See these cells? They got this bubbly cytoplasm. Yeah, that's all the lipid in there. That's all the sebaceous stuff. So you see these collections of these sebocytes, and surrounding them will be some darker basaloid-like cells, these darker cells here. But again, if you want to pick sebaceous adenoma, you tell me sebaceous-like cells, cells with this bubbly cytoplasm. That's it. It's a tumor of your sebaceous glands. Now, if you see a bunch of them, you might want to think about a genetic syndrome called the Muir-Torre syndrome. I'll show you the spelling into the table coming up. There's a table of all genetic associations, and you'll see it there. Muir-Torre syndrome is where you have a lot of sebaceous tumors. That's about probably the most important thing. If I see a bunch of sebaceous tumors, think about a genetic condition. Now, pilomatricomas are pretty darn common. Pilo is hair, matrix. It's a tumor of the hair matrix. So in the hair follicle, it's the matrix cells that turn to a tumor. And again, these are mostly benign tumors. It's basaloid cells of the hair matrix that are having hair-like differentiation. It looks like the basal cells of the hair. Now, what's characteristic is, here's the tumor. Now, I want you to notice, here's the epidermis. This is down in the dermis. See the pink area? Got a nice pink area. Then it's got that granular cell layer because it's a lot of basal cells, so very, very blue. And then in the middle is a bunch of dead cells. So let's look again. See this blue area? This blue area? These are all the basaloid cells. It's very blue because all the purple nuclei. See all the nuclei? This looks exactly like a hair follicle. This is what the basal cells of the hair follicle look like. They're very dark, they're very blue, dark and blue. And then notice as they come up here, they start getting pinker and pinker, and then the nucleus disappears. Gone. So you got all these like dead cells. They look like ghosts. You can kind of see like little white spaces where the nuclei should have been, but these are called ghost cells. Ghost cells. So in the center is a bunch of ghost cells. There's no nuclei. It's kind of like making a hair follicle. So in the center should be the hair, but here you got all this like dead cells from the tumor. So ghost cells. Now what's really cool is when you apply for your first job, you gotta go on an interview, right? First job, I finished my residency, I was like so excited, I'm gonna get my first job ever, I'm finally gonna get a big paycheck, get payday, baby, buy myself a nice car, live a good life. Well, I show up at the interview, and of course, what are they gonna do? They wanna see how good you are. So he says, you're a pathologist, let's look at a couple slides. Let's see if you get it. And so they put this first slide up, and I'm like, ooh, basaloid cells, ghost cells, pilomatricoma. And they're like, you're the first applicant we've done. We've done 100 applicants so far. You're the first one who knew it. And I was like, yeah. Got my first job over that tumor. So again, low yield for exams, but it's kind of cool because I remember I got my first job because I got this one right. Now, what about apocrine carcinoma? Well, these are another well-differentiated tumor. They look like ducts. They have an infiltrative growth pattern. So see these ducts here? Ducts, ducts. See the spaces? Ducts, ducts. Just ducts infiltrating, infiltrating. But the key is for an apocrine tumor, you're going to see luminal decapitation secretions. What the heck does that mean? Well, if this is the cells coming this way, oops, basically their apical cytoplasm just buds off. It just falls off into the lumen. These little pieces of surface just fall off. So that's what they mean by decapitation. The top, like the head, the top cytoplasm will fall off. If we look at this picture, I think you can see kind of some, the top of this, little blebbing here, little bumps there. I think you can see some pieces have fallen off right there. So it's kind of hard to really see this, but if you're a pathologist, you'll say, oh, I see the apical decapitation secretions, and you say, okay, it's an apocrine tumor. Apocrine pieces of the cytoplasm breaking off and going into the liver. No, it actually wasn't. I trained at Cedars, and then I went out to Kaiser Permanente, which was it's kind of like an HMO. So I went to Kaiser Permanente in LA and Harbor City, and I got my first job. First job, paycheck, big money. Crazy, huh? Yeah, it's a great day. So again, Barone, are you going to test me on these three tumors? No. But I want you to have heard of them. Tumor of sebaceous glands, tumor of the matrix, the hair matrix, the follicle, and tumor of the apocrine sweat glands. Cool. I've heard of them, and if I see them again, I'll say, okay, those are tumors Barone talked about. Now, here's what you better know. You better know dysplasia of the skin because it's going to turn to squamous cell. It's got a risk of going to squamous cell. Now, of course, they can't call it squamous dysplasia because everyone would know what they're talking about. So they call it actinic or solar from sun, actinic keratosis. That's what they call dysplasia of squamous cells. Oh, see, this is why we get paid big money. You got to know new terms. So dysplasia of your skin is called actinic keratosis. They call it AK for short. Or solar keratosis. This is what sunlight does. It causes dysplasia of your skin. Now, good news. Does every dysplasia go to cancer? No. A lot of times your immune system will clear it. But some cases will progress. So this is a precursor lesion that can transform into squamous in situ and then finally invasive squamous cell. So that's why we care about actinic keratosis. Now, this is due to sun damage, so you'll see it on sun-exposed skin. And it's very common in fair skin because you don't have much pigment to protect your skin from sun. So the lighter your skin, the more likely you're to get it. Now, what areas are sun-exposed? Your face. Every day your face is getting sun, right? Your nose, bridge of your nose, if you're bald, the top of your head, top of your ears, that's a common sight. Which lip? Which lip? Well, the upper one gets shading from your nose, so lower lip gets more sun. The dorsum of your hand, unless you're wearing gloves, every day you're outside, your hand's getting sun as well. So sun exposed, face, hands, dorsum of the hands, arms, whatever you show to the sun is going to have sun damage over time. Now, morphology. These are usually small areas that are kind of tan brown, rough, sandpaper-like. So if here's your skin nice and smooth, it'll be rough and bumpy, but red, bump, and roughy, rough, red, bumpy, red, bump, and rough, and then smooth again. So this bumpy area looks like sandpaper. It's rough and red. Sandpaper-like texture, that's what it looks like. Now, since this area is abnormal, it might make too much keratin. All that dead keratin at the top. Well, it may make a lot of keratin, a lot of keratin, a lot of keratin, a lot of keratin, and the patient will say, "Doctor, I feel horny." Yeah, because you have what's called a cutaneous horn. You have a cutaneous horn. You've got this dysplastic keratin that is creating this sticking thing. They call it a cutaneous horn. Somebody says he's horny, he's not kidding. This is called a cutaneous horn, and that's from abundant keratin production. Remember the term hyperkeratosis? That's thickening of the keratin layer, all that dead cells. You can also have parakeratosis, where you have thickening, but it's nucleated. So you still have nuclei, which is abnormal. So you can have parakeratosis and hyperkeratosis. Hyperkeratosis can lead to this cutaneous horn. Now I'm telling you this story for a reason. Farmers are out in the sun all day. They're in the fields, bending over in the fields. So where do they get sun? That's why we call them rednecks. They call them rednecks because they get this red, rough sandpaper skin in the back of their neck. They get dysplasia back there, so they call them rednecks. So what they said on the exam is, a farmer comes in saying, "Doctor, there's this thing sticking me here. It's sticking me." He picks it off. Yeah, you can pick this off. This is just keratin. It's dead tissue. You pick it off, and then it grows back. Yeah, it's going to grow back because the dysplastic epithelium is still there. So unless your immune system clears it, which it can, it may grow back. So that's a classic example of dysplasia. A rough red area that may have a cutaneous horn, you pick it off and then it comes back. That's dysplasia of the skin, potential precursor for squamous cell. Now, if we looked at the epithelium, we're going to see atypia in the basal cells. That's where the sun hits, those basal cells. So they become abnormal, and then you start getting abnormal keratin production. So the keratin layer can get parakeratosis with those nuclei, or it can get really thick hyperkeratotic, and you get these cutaneous horns. Intracellular bridges are present because this is normal skin. It's just dysplastic. It still has the desmosomes as it should. Now, if you look at the dermis, the sun is going to go through the epidermis and hit the dermis too, and it's going to damage the fibroblasts. Yeah, the fibroblasts of the dermis get damaged too. So they start laying down defective collagen. So you get what's called elastosis. This blue-gray elastic fibers, they're being produced by these sun-damaged fibroblasts. So let's repeat, the dermis starts looking blue on H&E. It's supposed to be pink. Collagen, keratin, should be really pink. It starts looking blue-gray because it's laying down these funny abnormal elastic fibers. So we call that solar elastosis. Yeah, damage of the dermis from sun. Wow. And then eventually, do you know when people see a lot of sun, they start getting all wrinkled? You get all wrinkled in some skin because you're damaging the fibroblasts. You're not making good connective tissue. So your thin skin starts getting wrinkly and thin and wrinkled skin. Yeah, I saw this woman in Venice. She's outside every day. She looks like she's 97 years old. And the other day I found out she's only 46. She looks 90. Her skin is wrinkled, it's sagging off her face. I felt so bad because it's all due to sunlight. She looks like 90 years old, and she's only in her 40s. When she's 90, I don't know what she's going to look like. Crazy. Yeah, she's out in the sun every day, all day long. All right, now, what do we do for actinic keratosis? Well, local eradication. So we can curette it, we can freeze it. We usually use topical chemo. Yeah, my grandma gets this on her hands, so they give her some 5-FU, some 5-fluorouracil, this topical cream, puts it on there, and it undergoes necrosis and falls off. So yeah, this is a chemo drug, but we're using it topical, and it will kill these abnormal areas. Another thing we can use is imiquimod. I can never say this name. It's like a crazy name, but I like it. Modulate your immune system. Immune modulation. It activates the immune system. Remember, we've used this already for several things. We can use it for a melanoma that you can't resect. So you can inject it to try to get the immune system to kill a melanoma. We use it for killing warts, genital warts. Very important for genital wart. Right? So you might want to get some of this for your friends. Because eventually your friends are going to say, hey, I got this thing down here. What do I do? So it's one of the things we can use to try to activate the immune system and clear genital warts. So pretty testable. All right, now here's what it looks like. Red, rough patches and macules on sun-exposed areas. Notice multiple areas here. Multiple areas, red and rough. Okay, under the microscope, it's kind of hard to see here, but I think you can see that the pink layer here has purple dots. Not supposed to have nuclei up here. This should just be pink. So this is called parakeratosis. I think you can see some of the basal nuclei are kind of darker than normal. darker than normal. So this is a little dysplastic of the basal layers, a little darker than normal. And then notice the dermis. What color? It's really blue. It's really blue. That's called solar elastosis. Damage to the fibroblasts, you have abnormal connective tissue, you get a wide over wrinkles really early. Now, here's a much better example. Take a look at this. You can see this much better. See the parakeratosis up there? Got nuclei up there where you shouldn't see it. So notice it's going to be kind of rough in this area. It's going to be rough because all this keratin, but it's kind of parakeratotic. It's abnormal. Notice these dysplastic cells. They're supposed to be dark only at the bottom layer. They're starting to get dark going all the way up. So this is starting to get dysplasia, almost carcinoma in situ here. It's getting abnormal. Now here's a classic example of a cutaneous horn. Doesn't it look like a horn? Person's horny. And you can pick this right off. This is dead keratin. It breaks right off. So this is an example of actinic keratosis. Actinic means sun-related. Keratosis means hyperkeratosis, thick keratin layer, or parakeratosis as well. Solar elastosis is the thick gray-blue elastic fibers due to the sun damage. You're seeing it here. Beautiful example of it. Remember, this should be pink. This should look more like this. The dermis should be pink like this area. But this is abnormal. Now look at all the hyper and parakeratosis here. Look at how thick this layer is. No wonder it's rough like sandpaper. And it's got some nuclei still, which is abnormal, parakeratosis. Look at these dark nuclei down here at the basal layer. This one. Oof. Look at this one. Oof. Okay, so eventually this is going to turn to squamous cell in situ, and then potentially squamous cell carcinoma. Now let's get right there. Squamous cell carcinoma, it's the #2 most common cancer in adults. Did you realize that? #2 most common malignant tumor in adults. Good news is it doesn't kill that many people, but it is very, very common. I see, when I was practicing in LA, I would see like 15 of these a day. 15 a day. But again, didn't kill many people. Now, it's more common in males, but older. Older is the key because it's the cumulative dose of sunlight over your entire life. That's the big risk factor, the cumulative dose. So how much sun have you seen in your entire life? You accumulate mutations until finally you get dysplasia. Now, other risk factors are putting hydrocarbons on your skin. Do you remember the chimney sweep? Yeah, chimney, chim true. They're going to get squamous cell of their scrotum because they would get naked and go through the chimneys to sweep it because they don't want their clothes to get all dirty, so they get naked. Now you don't see this anymore, but the chimney sweeps were getting scrotum squamous cell carcinoma. Now, another thing that can irritate the skin is not just sunlight, but irritation from ulceration. A chronic ulcer can get squamous cell. Draining sinus tracts, all that pus, irritates. Here's a big one, old burn scars. Remember, over time, scars should get smaller because of the contraction of the myofibroblasts. Scars should get smaller and smaller. If they say a kid is in a house fire many years ago, he gets severely burnt, and then many years later, his scar starts growing, starts ulcerating. No, scars should get smaller. They start ulcerating, they've now turned to squamous cell because you burnt that skin, you irritated it many, many years ago. And they give this a fancy name. When your burn scar gets an ulcer, they call it Marjolin's ulcer. Again, I think that should be a name for a Zelda game, right? Marjolin's mask. I don't know. No, it's Majora's Mask. Labia Majora's Mask. Yeah, that's what it was. All right, but anyway. Now, another thing that can irritate the skin is radiating it. Radiating your skin, you're at risk for cancer. Not having protection, xeroderma pigmentosa, or not having an immune system to fight it. So immunosuppression, so HIV, stuff like that. And then some HPV viruses can also be associated with squamous cell carcinomas. Now let's talk about genetics. For the genetics, the ultraviolet light can induce P53 mutations. And we know P3 is a marker for malignant invasive tumors. They can also have RAS mutations, so P53 and RAS, Now, the squamous epithelium has to mature. To mature, they use Notch. Notch is one of the things that cause things to mature. So if you lose the function, loss of function mutation in Notch receptors, the maturation receptors, well, now the skin is not going to mature properly, become immature and neoplastic. So Notch mutations, RAS mutations, P53, there's a number of mutations here. All right, now all of these skin tumors pretty much are going to be sun-exposed areas, sun damage that causes them. And what I want you to remember is squamous cell looks ugly. You don't bring it home to mother. It looks ugly. Don't show it to your friends. Basal cell looks beautiful. Bring it home to mom. She'll like it. Basal cell is beautiful. Squamous cell is ugly. Because they often show you the picture and ask you what it is based on growths. So squamous cell is usually a tan nodule with extensive ulceration. Most of this nodule's ulcerated, so it looks ugly. So this is on this poor guy's forehead, no hair to protect it, so we wound up getting a nodular squamous cell right here. Now, in this picture, I think you can notice here's the normal epithelium. Nice, look at the granular layer, nice granular layer up there. So nice epithelium, and all of a sudden, whee, let's invade, let's go way down, whee. I think you see this area became very dysplastic and started invading down. See, this is just invading down. Okay, now if we take a look at the blow-up of this area, I think you can see these squamous cells. Here's the nests of them. Nests of squamous cells are invading the stroma. Nests of squamous cells. All right, now take a look. What is this pink whirling thing? Well, keratin. Squamous cells are supposed to make keratin. So you start to see keratin pearls here, keratin whorls. Now if you look over here, do you see the lines or connections across like this? These are called intracellular bridges. They still have desmosomes, connections between the cells. So intracellular bridges and keratin production, every time you want a big squamous cell, you gotta give you those clues. See, it's gotta be at least well or moderately differentiated. If it's undifferentiated, it's very hard for students to pick it up. So I gotta give you keratin production and intracellular bridging, which are desmosomes. When you hear that, squamous cell. If I heard glands and mucus, adeno. Glands and mucus, adeno. Glands and mucus, adeno. Keratin pearls and intracellular bridges, squamous cell. That's the key. Now again, would you take that home to mother? No thank you. Another big nodular mass. This is right behind the ear. And it's mostly ulcerated. Nasty looking. Nasty. And then of course, would you kiss that? I don't think so. Look at this. You got a nodule here, and again, it's mostly ulcerated. And this is the kind of thing they like to show like a step 2 or step 3. They'll just show this picture and ask, what is it? Now, here's the rule. Upper lip has some shade. So lower lip for squamous cell. Basal cell comes from the basal hair follicle cells. Where's there more hair? Upper lip. Upper lip. There's some lower lip hair too, but upper lip is the key. So upper lip for basal cell, lower lip for squamous cell. That's the rule. Now again, to tell it apart, you actually biopsy it. But basal cell is the upper, squamous cell is the lower. Okay, so look for ulcerated nodules. They look nasty. Now the good news is they're usually resectable. So we can usually cure these. And they rarely, if ever, metastasize. Less than 5% of metastasize. So your chance of cure squamous cell is very good. Very good. Remove them and you're usually cured. Now the same is not true of squamous cell of the lung, squamous cell of the bladder. No, those are much worse. So mucosal squamous cells like oral cavity, lung, squamous cell of the esophagus, they're much worse. Okay, so skin squamous cell, usually we cure it. Squamous cell of the esophagus, lung, oral cavity, not as good. See, the internal ones are much worse. All right, and again, look at this thing. That don't look good to me. Looks nasty. And look at this bump here behind this. This must be a lymph node. That looks like a paraauricular lymph node. Looks like this squamous cell is now metastasized. So yeah, they can spread. Definitely have to catch them early. All right, now the precursor for these are going to be dysplasia, actinic keratosis, then it can turn to in situ squamous cell, and then invasive squamous cell. Now, actinic keratosis just has dysplasia at the lower level. Squamous cell in situ has all the layers of atypia. So that's the difference between dysplasia, which is the lower level, and in situ cancer, where all the layers, all the way up is abnormal. Now, these are deeply invasive into the subcutis. We start going down to the dermis. You can go all the way down to subcutis. They could be well differentiated, moderately, or poorly. On your exam, it will always be well or moderate because they got to give you those clues. Other mucosal ones are oral and lung and esophageal are much worse. But again, you want me to pick it, you have to give me some pink keratin production. Give me that pink keratin pearls, those keratin whorls. You can't just give me invasive tumor cells. I won't know what it is. Got to give me a clue. Give me the desmosomes, give me some keratin, then I will pick it. Now, there's one variant that they really like to test. It is called the keratoacanthoma. This is a very well differentiated one. So why do they care? Because of how it presents. It's usually on the dorsum of your hand, and it grows rapid. It's like a volcano, a rapid appearance of like a volcano. It literally, here's your skin coming across, here's your skin coming across, and all of a sudden you see this dome shape like a volcano. This dome-shaped mass. So rapid growth of a cup-shaped or dome-shaped tumor. In the middle is this central cavity or crater, and there's keratin, little keratin debris coming out of it. So it really looks like a volcano, keratin coming out. So cup-shaped tumor with a central depression filled with keratin debris, that's the classic description. But I want you to remember, it grows so fast, it outstrips its blood supply. So what happens to it? It suddenly undergoes necrosis and falls off. It literally undergoes necrosis and just dies. It just falls off. How awesome. Only the good die young. Why can't the poorly differentiated ones do this? No, only the well ones, only the good die young. So remember the fancy term, when it comes like a volcano very rapidly and then undergoes necrosis and literally falls off, and usually here on the dorsum, they said just undergoes necrosis, fell off, that's a keratoacanthoma. $10 word for well-differentiated squamous cell. Now I'm just going to do one more and then we'll be done for the day, and that is basal cell. Basal cell is the #1 most common of your skin tumors. #1. In fact, every day I diagnosed about 25 of these. Now I was in LA, which you get a lot of sunlight, but even in the rest of the world, even in Indiana, basal cell is the #1 cancer in adult humans. #1. Good news is, it doesn't kill that many people. It's malignant, but it doesn't usually spread. It's usually locally very aggressive. Now again, it's one of the most common invasive cancers in humans. Good news, it's slow growing and rarely if ever spreads. So good news, we can resect it. Now, I've been doing medicine about 20 years now. In my 20 years, I've only seen about 10 of them that have metastasized and killed. That's it. So they do kill, but pretty rare. Now, incidence increases with age. The older you are, more likely to get it. Having immunosuppression, your immune system can't stop it. Having fair skin, you get more sunlight damage. And of course, xeroderma pigmentosum, it's a risk for most of these sun-related skin cancers. Now, appearance. It's on sun-exposed, hair-bearing skin. So upper lip will be more than lower lip, although lower lip can't have it, but upper lip is more common. Anywhere in the face, because there's fine hairs. There's fine hairs on the face. So anywhere where there's hair-bearing hairs, you can get it. It's a tumor of hair follicles. Now the classic description looks like a pearl, a pearly papule. So a raised nodule or bump, and it looks clear. You can almost see through it. You can see through it, and you'll see blood vessels called telangiectasias. So these are pretty. You take these home to mother. So wait, let me see. Oh no, I don't show you that one yet. So I wanted to show you what it looks like, but I don't have the picture yet. It'll come up. So they're like pearls. They're clear, they're shiny, they look good. Now over time, this center could get a little ulceration. So I see this bump. In the center, when it gets bigger, you get a little ulceration in the middle. They call it a rodent ulcer. It looks like a rat came in, took a couple bites out of the middle, but it still looks good. It just got a little tiny ulceration. It's not super ulcerated like the squamous cell is. Now, it is locally invasive. It can invade like crazy. I had this guy once who had it here when I was in med school. I was a medical student. It was right here, and he let it grow and grow, and it was so big. When he came in, I actually saw it moving. I was like, sir, there's something on your face moving. He goes, what? And I looked closer, it was maggots. There were maggots growing. They were just crawling around the tumor, eating it. Yeah, I was like, doesn't this guy have friends? And I was like, what do you do? Don't you leave the house? He goes, no, I'm an internet. I do all my work on the internet. I never leave the house. I never go out. I order pizza. I was like, didn't the pizza guys, like, Did they think you were a monster? I mean, it was like, I mean, how do people let it get like that? I mean, it was just terrible. There were maggots growing on it. Now, I didn't get to, I was a med student. Med students, we don't get to do cool surgeries. But they did basically a hemi-facectomy. They took half his face off. Now, as a medical student, I didn't get to do surgery, but I get to see him afterwards. I have to unpack the wound and repack it because they can't do a skin graft right away after a big surgery like that. They got to let it heal a little, and then they'll go back and they'll do a skin graft to get the skin back on. And I had nightmares. You remember Batman's enemy, Two-Face? I walk in, this side's great. On this side, I mean, you take the packing out, I'm looking at the palate vibrating as he's talking. I'm watching the eye muscles move as he's moving his eye. I mean, it was literally like Two-Face. It was like face-off. Half his face was gone. And I never did things faster. I'd be like, hi, Mr. Brown, how you doing? And I'd unpack it, put the new packing in, say, see you tomorrow. I literally had nightmares about that guy. Because I'm looking and he's talking to me and his palate vibrating. I'm watching the oh. I still, just thinking about it gives me the quivers. So here's the rule. Take them out early and you cure them. If you leave them, they're very locally aggressive. They'll invade the bone. You'll have to take half your face off. So the key is get these things out early. Now they can spread. Like I said, I've had 10 to 15. I think I've actually seen them spread and kill people. But they usually don't spread very much. So take them out, you're good. Now, under the microscope, they resemble the normal basal cells of a hair follicle. That's why they call it basal cell. Okay, now they tend to line up though. So at the edge of the tumor, so if you're looking at a nest of tumor cells, there's the tumor cells. All the tumor at the edge line up like a picket fence. So they give this a name. When it all lines up like this, they call it palisading, like a picket fence, palisading. They're lining up. So that's a very classic feature. So basaloid cells with a palisading growth pattern, just the ones at the edges, they line up at the edge. So they call this a palisading arrangement of basaloid cells. That's the classic description. Now, they can be multifocal, they can be nodular, grow up and down. So multifocal is usually multiple areas but superficial. Nodular is one that's big and going deep, and this is the one that often invades bones and stuff. So that's just the two ways it can grow. It can go superficially across the skin, or it can grow deep into the skin. It's a nodule. Now, Hugh Jackman, I told you, Australian, down by the equator, they're getting sunlight. Now, he's been trained. His wife said, get that thing looked at. Now, most men are like, yeah, whatever. But he's like, I was trained. Deb said, get that mark on my nose check, and boy, she was right. I had basils. Basils? I think he's a chef. Basil, that's what you cook with. I have basal cell carcinoma. So don't be foolish like me. Listen to your wife and get yourself checked. Use sunscreen. Now, he's had 3 of them now. I know, ladies, he makes bandages look good too. I know. But he's had 3 of them. Yeah, and here's what the tumor looks like. There's the epidermis, and then you see these darker cells that are just invading like this? These nests of dark cells? This is the basal. And do you see at the edges? See they're dark at the edge? They're all lined up at the edge. They're all lined up, lining up. That's that palisading growth pattern. So they're all lined up around the edge. That's classic. And by the way, here's the secret. Basal cell retracts. So do you see the way it's an artifact? When you make a snare, do you see the way there's a white space around it? That's a retraction artifact. Whenever I see it, basal cell. Basal cell. So it's lining up like a good boy should. That's a palisading appearance, palisading at the edges. And I see the retraction, that's basal cell. Now, what did he do? Did he use his retractable claws and did cut it off himself as a retractable claws? Or that's a shave biopsy. You can shave them, but the problem is if you shave them and you cut through them, they come back. That's okay. As long as you go back and resect it, it's all good. But you gotta get complete resection here. So maybe he has Cyclops to burn it off, like take his goggles off and just burn it out. But here's what I do know. There's only 3 ways you can kill Wolverine. That's it. There's 3 ways to kill Wolverine. So you want to kill him? Bad guys take notes. If you want to kill him, number 1, take away his healing factor. Take away his healing factor, you can kill him. Number 2, decapitate him. Cut off his head, that won't regenerate. And then finally, the number 1 answer, steal his sunscreen. Because he's had 3 of them. It's probably the same tumor, and it keeps coming back because his tumor has regenerative properties too. So it keeps coming back. He'll never be able to kill his tumor. So steal the sunscreen. Now that's kind of a joke, but it's still pretty cool. Now here's what we call it, pearly papule. Doesn't it look like a pearl? It's smooth, it's shiny. You can almost see through it. Do you see inside? Do you see the blood vessels? These are called telangiectasias. So it's almost translucent. You can see inside it where the blood vessels are. Whoa, smooth and like a pearl you give to your mother. Pearly papule. That's how to describe it, papule. Now, when it gets bigger, the center may get a little ulcer, but it's still not bad. Squamous cell is all ulcerated. This might get a little rodent ulcer, look like a rat took a few bites. So even when it ulcerates, it doesn't look that bad. Now, under the microscope, you'll see these invasive nests. And again, if you look at the edge, see where it's darker at the edge? It's dark at the edge because these cells are lining up. This is called a palisading pattern. And they're very dark blue cells because that's basal. The cells are dark. And see, they're lining up. And then look at the retraction, the separation or retraction artifact. It's characteristic. Whenever I see that, it's basal cell. But you figure you look for the palisading growth pattern. Palisading in the skin, that's a basal cell. Palisading, small hyperchromatic nuclei that line up. They arrange in parallel like a picket fence at the edges of the tumor nests. All right, now what about genetics? There's always genes for this, right? P53 for squamous cell, RAS for squamous cell, Notch mutations for squamous cell. Now for basal cell, they often have mutations in Sonic the Hedgehog. Sega, the Sonic the Hedgehog pathway. Now, Sonic the Hedgehog was important for lateralizing right versus left. So if I knock that out, I won't know right from left. So I'll make one brain, I'll get holoprosencephaly and a cyclops. Holoprosencephaly, holoprosencephaly and a cyclops. Because I won't be able to lateralize. I might make too many fingers. I might make 2 fingers and toes. I'll get polydactyly. I can get cleft lip. So if you knock it out, it looks just like the cows. So knockout in Sonic Hedgehog is important for embryonic development, lateralization of the body, and if you knocked it out, you could get Cyclops babies. But here, we're going to turn it on, because it's also important for development of hair follicles. So Sonic Hedgehog is for lateralizing the body and for growing hair follicles. So if you turn this on, the hair follicle grows too much, and you get basal cell. The basaloid cells of the hair follicle go crazy. So mutations in Sonic the Hedgehog, where you activate it, are found in both sporadic basal cells and hereditary. And the reason we figured this out is because of the hereditary cases. Whenever we have hereditary mutations, we learn about what genes do by seeing what goes wrong when they're mutated. So these are like experiments of nature. When you find a patient with a mutation, we can learn, what gene is mutated? That gene must be for this because they're getting these features. So these are like experiments in nature that we can learn from. And that's what we learned about Sonic the Hedgehog. We learned it because we saw this hereditary case. It was called the nevoid basal cell carcinoma syndrome, also known as Gorlin syndrome. This is where they have an autosomal dominant mutation in PATCH, which is the receptor. It's the receptor for Sonic the Hedgehog. It's the receptor. Now, you're normal. Here's what happens in you. Here's Sonic the Hedgehog growth pathway. There's Sonic the Hedgehog. He's rolling around, and then he sees a receptor. The receptor for him is called PATCH. Now, normally, PATCH is binding to smoothen. It holds on to smoothen. That's its job. Now, when along comes Sonic, and Sonic attaches, I can only hold on to one thing at a time. It lets go of smoothen. When it lets go of smoothen, now smoothen can turn on transcription factors, and you get growth and maturation. Okay, so this is one of the many growth pathways in our body. Now, what happens in this basaloid cell carcinoma syndrome is they're born with a mutation in PATCH. It's a PATCH mutation. So notice, it's mutated, so it can't bind smoothen. It can't bind it. So smoothen is always free. If smoothen is always free, it's always sending the growth signal. Always sending the growth signal. Your hair follicles are going to grow like crazy, and you're going to get basal cell cancer. See, that's how we learned about Sonic the Hedgehog, because they got all these basal cell cancers, Then we found the patch mutation, and patch is the receptor for Sonic the Hedgehog. Okay, so mutations in the Sonic the Hedgehog pathway, particularly patch, are very important for developing basal cell either genetically or sporadically. Sporadic, not mutate these things and you can get growth. All right, this last table, and I promise we're done for the day. I told you there was a list of cancer syndromes. Cancer syndromes, familiar, running family, cancer in your family, that have cutaneous findings. So I told you before about the Muir-Torre syndrome right here, Muir-Torre syndrome. This is a genetic dominant disease where they have mutations in the mismatch repair genes. Remember DNA mismatch repair? So these patients are going to have a number of cancers running in their body, particularly colon cancers, but they're also going to get, colon cancer, they're also going to get sebaceous tumors of their skin. So they'll get sebaceous adenomas, a bunch of them. So that might be a good clue. You see a bunch of sebaceous adenomas, and they ask you what cancer they're at risk for? Colon cancer. Colon cancer, that's a Muir-Torre syndrome. Again, not common. Not common. Not common. Now, much more testable is ataxia telangiectasia. That gets telangiectasia in the skin, right? That's a mutation, it's a recessive mutation, the ATM gene. And this is important for DNA repair after radiation injury. So when you get radiated, you're going to get mutations that can't be repaired because ATM is supposed to sense the damage and then tell the P53 to stop the cell and BRCA to fix it. Okay, so for DNA strand breaks particularly, it's important for them. Now, what kind of tumors do you get? Well, I want you to remember ataxia, telangiectasia in the skin, microbial infections, and malignancies, particularly breast cancer and leukemia. Breast and leukemia. Breast and leukemia. Now, we talked about the nevoid basal cell carcinoma. Obviously, they got basal cells in the skin, multiple, and this is due to the patch mutations. Patch mutations. They get lots of basal cell carcinomas. They also get cysts in the jaw and other things too. Now, we mentioned Cowden syndrome a little bit. Cowden P10. Cowden P10. This is a dominant mutation in the P10. So now they're going to be at risk for this. They get some of the hair follicle tumors that we talked about, but they're going to get cancers like adenocarcinomas of the breast. They can also get prostate. They get thyroid. They get endometrial cancers. So multiple cancers running in the family. Melanoma we talked about, that was chromosome 9, like 9 Mile, Jamaica, Bob Marley. And this is a mutation in the P16, INK4 gene. When you're born with an emergency brake missing, you have a high risk of melanoma. Neurofibromatosis, that one's obvious. You have neurofibromas in your skin. We talked about the NF1 on 17 letters in von Reichenhausen. And we talked about NF2, chromosome 22, NF2, 22. You'll have 2 tumors in your head, you'll have bilateral schwannomas, and you'll also have meningiomas too. Tuberous sclerosis, this is a hamartomatous disease. So tuberous sclerosis 1 makes hamartin, tuberous sclerosis 2 makes tuberin. Now you're going to get all these hamartomas throughout your body, including in the skin. Remember in the skin they got ash leaf patches, they got Sjogren's patches, and they got the adenoma sebaceum, which is really angiofibromas. Looks like acne. Looks like acne. Angiofibromas of the face, which is very characteristic. And the last one is xeroderma pigmentosa, the children of the night. They have to avoid the daylight, they have to avoid the sun, or they get lots and lots of skin tumors. So they get basal cell, they get squamous cell, they get melanomas, they get all skin cancers. So melanomas and non-melanoma skin cancer will occur if they see sunlight. Right, that's just a table just to remind you of some important genetic diseases that have cancer, and they have skin lesions too. All right, we got a couple more tumors to do, but we'll do it next time. So I'll see you guys on Monday. Have a great night, and good luck on your exam. Good luck on your exam.
I just let you know it's over. Oh, it just finished?
Any questions, by the way? You guys already left. Go study farm. All right, see you next week.